So we have to just have it.
What's that? Right? How do we control the sound? Hierarchies work.
Okay. Left and right, yeah.
Roger Powell. Like instead of Angel.
No, because they said we will also say, but someone also come up with it.
Yeah.
But was this person?
Okay.
Turn off their phones.
Yeah. Before we start, I'd like to ask for everyone to silence their cell phones so that we can respect all the speakers. Yeah. Good afternoon. We would like to now officially begin the 2026 Asian American Cancer and Diabetes Health Symposium.
Today, we gather during Asian American and Pacific Islander Heritage Month to celebrate the strength, resilience, cultures, and contributions of Asian American communities while addressing important conversations around cancer, diabetes, tobacco prevention, mental wellness, health equity, and access to care.
We are honored to welcome leaders, physicians, researchers, survivors, caregivers, students, and community advocates joining us both in person and virtually.
Please join us in welcoming our opening speakers and City of Hope leadership. We would like to invite Ling Wu from American Cancer Society, Sophia Young from City of Hope, Scarlett Koo from Lions Club, Angel Peel from Lions Club, and Kim-Lin Ashing from City of Hope to the stage. Let's give a round of applause to the leaders who made today's event possible.
We are so delighted to have you here at City of Hope for our annual symposium. It's Asian Pacific Islander Awareness Month, and this is so important to us at City of Hope, addressing health equity, health disparities in the Asian and Pacific Islander community. So we welcome you to City of Hope. We have so much and a packed agenda for you, so I'll be brief. I just want to say welcome and ni hao.
So we can stand here, Dr. Kinimashi. How about Scarlett? Scarlett Koo, please come. And say something. Yes, please. Oh, okay.
Distinguished guests and Fellow Lions, good afternoon. My name is Scarlett. I'm the American Cancer Society chair this year. And also I'm the Lions Club International past district governor from 2023 to 2024. So first of all, thank you very much for taking the time to join us at today's symposium. It is truly my honor and pleasure to see so many people who care about health in our community gathered today. The purpose of the organization, this event is not only to provide professional knowledge, but also to create an opportunity for sharing, learning together. Health is our greatest wealth. Prevention is better than cure, and the knowledge has the power to change life. I would also like to express my sincere appreciation to all of our speakers, sponsors, volunteers, and everyone working behind the scene. Without your support and dedication, today's event would not be possible. So I hope everyone gets valuable information and inspiration from today's program. Wishing all of the good health, happiness, and the continued blessings. Thank you.
We would now like to invite Ms. Ling Wu to talk.
Thank you. Good afternoon. My name is Ling Wu. I'm the co-chair of the American Cancer Society Relay for Life. And we started this knowledge sharing event since 2010 when we started the Chinese Relay for Life. I just want to say that we know knowledge is power, and we know knowledge can save lives. The American Cancer Society's education program. So I'm really happy that we can get this ready going for the Asian American community. You know, we got the AI technology to translate to different Asian languages, so we can have so much more power in having English presentation and Asian language translation. So I hope everybody make use of this knowledge, because knowledge can save lives. Thank you so much for your support and participation. Thank you.
Let's welcome our PCC Roger. Yeah, because our district governor, Angel Pell, has other event, so PC Roger will represent.
Believe it or not, I am not Angel Pale. District Governor Angel Pale could not be here today because she had another engagement. But as I stand in for her as the district treasurer, Lions have a long history with the City of Hope. We have been supporting the activities not only for cancer, but diabetes and all forms of diseases that cause these various problems. We have supported this for many, many years, and it is with great pleasure that I stand here today and deliver a check to who wants the check? It better be somebody from the City of Hope, from the City of Hope for $1,000.
Thank you. Let's read all the club's name, okay? LA Chinese Lions Club, LA Envision Lions Club, come to the stage. Judy Lee, Fred Lee, Jeff Lee, and Jenny Shah, come to the stage. Thank you, all the Lions Club donation. Thank you.
We would now like to invite Carol Fung, cancer survivor, long-term volunteer with ACS, and someone who, without her support, we wouldn't have been able to make it this far. I would now like to invite Carol Fung to the stage.
Is our long-term cancer survivor, and she did a lot of amazing work in the community. We wanted to honor her. People call me. Wanted to appreciate this people here from the lunch. This one for the this one for the honor them. Honor them and hold it up to the side. What you say? Yourself. Like the rich one to appreciate our love and everyone.
Next, we would like to appreciate our lunch sponsor, Regeneron. Regeneron, would you please come up to the stage?
Next, we would like to also thank Lee Kum Kee for sponsorship today. Also want to thank iHealth as well for sponsoring today.
People up. Take a picture.
We would now like to invite Safa Mohammed, Van Ed Tran Chi, Arthur Yuen, City of Hope Asian Pacific Community, and City of Hope HACE to the stage to take a picture.
He's representing City of Hope. Page 2, right? Page. So that's why he's so important. He's like doing a lot of work to get us. Safa, I wanted to also honor her because like she is the big supporter of this symposium. Thank you.
I'm going to present for our assembly member, Mike Fong. He cannot come today, so I just called the name. Please come to the stage. So Director of Kindling Action, Ling Wu, Virginia Huang, Maggie Lee, Angel Pell, and Sophia Yang, Sofa Mohammed, Teresa Chen, Claire Chen, Angela Unayan, Antonio Wu Zhang. Come to the stage. Antonio, where's Antonio?
One more, 1, 2, 3.
We'd like to welcome you again to the 2026 Asian American Cancer and Diabetes Health Symposium. Once again, I'm Richard. I'm one of your MCs. I'm a rising senior at MIT.
And my name is Victoria. I'm also going to be the MC, and I was 2020 Miss LA Chinatown 4th Princess.
Now let's welcome our opening speaker, Dr. Ashing. Dr. Ashing is a distinguished professor and the founding director of the Center of Community Alliance for Research and Education at City of Hope. With a doctorate in clinical psychology from U Colorado Boulder, she is recognized as an advocate scientist, advancing population health science and practice. we'd like to welcome Dr. Ashing.
Thank you again. I feel like a rock star being called to the stage. So, ni hao, welcome. We have great speakers who are much more eloquent and who are even greater experts in the issue of health disparities and research to save lives and to bring health and well-being to the Asian and Pacific Islander community. So thank you. And we are so grateful for your participation and all of your support to make this happen. Thank you.
Thank you, Dr. Ashing. We would also like to thank Swanika, who made many beautiful gifts for our speakers today. We will now transition to our first speaker. I'd like to invite Mr. Patrick Casebolt and Angela to the stage.
Okay, good afternoon, everybody. I hope we're all having a good time right now. My name is Angela Nayan, and I am one of your two youth MC leads and also co-chairs for this event. I'm currently a junior at Walnut High School, and I've been with ACS-YA for almost 4 years now. I'm very excited that you guys are all joining us today, and I hope that you will learn some things from all the amazing speakers that we have. So first, let me introduce our speaker, Mr. Patrick Casebolt, who is our first keynote speaker. He has a master's in public health and is a project management professional. He is focused on aiding communities in preventing cancer and catching it as early as possible. And this can be done through education and also earlier screenings and making sure you do your annual screenings, please. Do your annual screenings. He's also an associate director at the American Cancer Society, which means he often interacts with local hospitals and cancer centers to help design and implement large-scale initiatives that can improve on how care can be delivered on a systemic level. As a local in South California, his work heavily influenced patients within the area and focuses on how our cancer data can be better understood and easier to be accessed for the general public. Today, he will be presenting on the topic of Asian American health in numbers, data, stories, and impact. And this is so important now that we're in the month of May, as this is Asian American and Pacific Islander Heritage Month, as we need to better understand the bigger picture that we make up. And so please join me in welcoming Mr. Patrick Casebolt.
Right. Hopefully everyone can hear me okay here. Great to be here. I want to start by thanking everyone for being here. I know there's a lot of places you could be on a Saturday afternoon especially. So thank you for being here and wanting to learn more about your cancer risk and how you can prevent cancer in your life and your community. I also want to thank City of Hope as well for hosting this event, all the planning committee, all the people that were just up in the front of the stage for doing this every year. I hope this event goes for many more years to come. It's a really great opportunity to learn. Moving on here, I guess I want to talk first about what my job is and why I'm kind of in front of you. I work with a lot of hospitals and cancer centers, as was mentioned. And one thing I've learned from this work, it is very important that you go and see your doctor and that you learn about how you can prevent cancer. But a lot of these conversations do actually happen in the community, and it's not always starting with the doctor, but it's starting with a conversation with a friend. So I want to introduce you to something called the social ecological model. It's basically just a few different levels at which health is influenced, and specifically influences an individual. And we're tempted often to think that there are environmental factors, policy, community, institutions like hospitals and cancer centers, interpersonal, and then also our own knowledge, attitudes, skills, and behaviors, as you can see in the bottom right, that actually influence how our health goes. But I want to encourage you to think about how we can push upwards and empower you to think about how we can push upwards, both in your own individual life and how you can influence your own health, but then also being that we're all part of an Asian American community here, that we look at the interpersonal side of things as well and try to work towards working with friends, family, social networks, neighbors, et cetera, and help them to understand their cancer risk as well. So 2 questions to keep in mind today throughout the day is first, what can I do for my own health? And then second, I also want you to think about who else could actually benefit from this information. And the challenge I want to give you for after you go home and you processed all this information is to, 1, take 1 step, and then second, to share 1 step. So you can take 1 step for yourself and share 1 step with someone in your community. And that's how we're going to get the word out about this. So what does this look like? This ripple effect could be, a spouse encouraging their loved one to get screened, could be a child helping their parents schedule an appointment to go see their PCP. It could be a friend sharing information about a cancer preventing vaccine. And in general, it's you explaining something you learned at an event like this. So I hope that you will take that charge there and do that after. So I'm going to start with a ANHPI population overview. Just for context, ANHPI is Asian American, Native Hawaiian, Pacific Islander. So when I refer to it, that's what I'm referring to. By the numbers, so we see as of 2023, there's approximately 25 million Asian Americans of a single or mixed race in the United States, and then a 1.7 million NHPI individuals in the United States. So this is around 7% and 1% of the overall population, respectively. And Asian Americans are actually the fastest growing population in the United States. The size projected to double since 2016. It's going to double by 2060. When we look at how different subgroup populations, kind of influence the overall population, we see that there are 6 origin populations that really account for 85% or 86%, of the overall Asian American population. So it's Chinese, Indian, Filipino, Vietnamese, Korean, and Japanese. And then we have a bunch of other origin groups as well here, no less important, but just a lower proportion of the overall Asian American population. For NHPI population, we see that Native Hawaiians are the highest, and then we have the respective other groups there as well. And looking at Asian Americans and how they spread across the United States, California is actually the most populous state in terms of Asian American population, and then Texas and New York are kind of the second and third most. Hawaii is the only state that has over 50% of the population is Asian American. So first, I'm going to talk about cancer risk, which is your risk for actually getting diagnosed with cancer as an Asian American, Native Hawaiian, Pacific Islander, and specifically looking at male individuals. So again, circled at the top here. I know there's a lot of information on this slide, but I'm going to break it down. So you'll see on the left-hand side the different subgroups that you're looking at, and then across you'll see the first, second, third, and fourth most diagnosed cancers for those respective groups. Focus in first on the first most common cancer, and you'll see here that prostate cancer is in general the most prevalent across the different subgroups. This is actually in line with the overall U.S. population, that prostate cancer is also the most incident cancer for the overall U.S. population of men. So the same goes for these populations here. We'll see an outlier here in Chinese, Vietnamese, Laotian, and Chamorro-Guamanian individuals that have lung and bronchus cancer as their number one most diagnosed cancer. And then we'll see colon and rectal cancer as the top in Korean, Hmong, and Cambodian individuals. And zooming back out again, you can take a look at this again at whatever respective subgroup you identify with, you want to learn more about today, and look across the first, second, third, and fourth. Point out a couple of other things here. One is the subgroups that I've highlighted here on the left. They do all have liver or intrahepatic bile duct cancer in their top 4 cancer for Chinese, Vietnamese, Laotian, Hmong, Cambodian, and Tongan. And this is especially interesting because liver cancer is actually not in the top 10 of most diagnosed cancers for the overall US population. So in particular for these populations, they're accounting for a significant proportion of the type of cancer that they're getting, again, within the male population. For Korean and Samoan individuals, stomach cancer also appears in the top 4. That's not one that appears in the top 4 for the overall US population. So another relevant one to mention there. So next, we're going to pivot over to female AA and HPI cancer risk. And we have a similar looking one. This is different because it's looking at females, but we'll again look at our first most common cancer. And in this case, we see that breast cancer is the most common cancer. And this is also, as I said, in line with the overall US population. And I encourage you to take a picture if you're curious about the first, second, third, and fourth cancers as well. But you'll notice again that liver cancer does appear on a couple of them as well for Laotian and Cambodian. Next, we're going to look at cancer mortality. I don't like to talk too much about mortality because I think it's not the best way for us to be motivated to change our cancer behavior, but I think it's still important for us to talk about. So cancer is the leading cause of death in the following populations. That's Chinese, Filipino, Korean, and Vietnamese. And this bar graph here is looking at death among males. And what I'm going to do to just make this a little bit easier to understand is basically you just want to look at the bottom bars here. The whatever falls to the bottom is the highest amount of highest mortality rate. So in this case, we see that lung and bronchus cancer is the top death rate for these different groups across the different bars. And then for women, we do the same exercise looking at lung and bronchus and breast. For several ones will appear down at the bottom. So for Guamanian, Filipino, Samoan, and Asian Indian, breast cancer is most common. For Native Hawaiian, Chinese, Vietnamese, Japanese, and Korean, lung and bronchus is the most common. And again, this is in women specifically. Another thing I want to mention about cancer mortality, Asian Americans do actually have a 40% lower overall cancer death rate than when compared to the white population. However, what we do see in Asian Americans is that the liver cancer rate is actually 40% higher, and that the stomach cancer death rate is actually 2 times higher. So in particular, this is not saying that the overall cancer death rate is higher, but that the proportion of the cancers that Asian Americans get is higher for these specific cancers. Next, looking at cancer prevention, which I'm sure everyone is wanting to learn a little bit more about, what can I actually do about it? And one thing I want to make a point of is that the earlier that you find a cancer, the easier it is to treat. And this is done ultimately through screening, and something that I encourage you all to, talk to your doctor about what your screening recommendations are based off of your respective risk. But we'll see the prevalence of cancer screening among Asian Americans varies a little bit here. Unfortunately, we don't have a lot of great data. We only really have it for Asian, Indian, Chinese, and Filipino, at least disaggregated for those populations. But we'll see that Filipino individuals actually do better than the overall Asian population for cervical and breast cancer screening, but then a little bit lower for colorectal cancer screening. And then for Chinese populations, lower for cervical and breast, and then higher for colorectal cancer screening. So there's either way, there's already still improvement or room to improve here. As you can see, we're still, even if it's a little bit better, it's still 51%, right? So there's room to improve. For lung cancer, AH and HPI individuals are about 18% less likely to be diagnosed early. So the early diagnosis rate is just lower there. Again, that has to do with screening. Some other points I want to make: 44% of cancer deaths can be prevented through changes in behavior. And those same changes in behavior can actually help us to avert 60 to 70% of cancer diagnoses as well. So now we're going to talk about some of those behaviors. And some of them are ones that people might be more familiar with, right? I think a lot of people are aware that smoking is something that they want to pay attention to. You'll see the rates kind of vary here a little bit when we're comparing across different subgroups that we do have data for, which again is pretty minimal. And same thing with excess body weight. The point I want to make with smoking as well, just to encourage everyone to think about this, is that it's really never too late to quit smoking. One very interesting fact about smoking is that within 5 to 10 years of quitting smoking, your cancer rate or cancer risk actually drops by around 50% for certain cancers. So you have a pretty significant change if you make that positive step to quit smoking. And when we look at Native Hawaiian Pacific Islanders, we see that current smoking, obesity, and lack of physical activity are all more prevalent in that population. And then cancer screening is lower, with the exception of breast cancer screening. Again, the overall percentage is around 66%, so there's still room for improvement. But relative to the non-Hispanic white population, we're seeing that there's a slightly higher rate of breast cancer screening in NHPI individuals. Lung cancer in never smokers is something that's, still there's a lot of studies going into this and determining more about it. But this is something that does happen. People will never have smoked before, and they end up finding out that they have lung cancer. And this is actually 4 times higher in Asian American women and 2 times higher in Asian American men. And some of the reasons that we could attribute this, we have some data to show it, but there's still more that we need to know, is secondhand smoke can influence this. Radon can influence this, so radon exposure, air pollution, and then cooking oil fumes as well. And the thing I want to mention with cooking oil fumes is that's something that, you're not going to maybe cut out frying foods altogether. But, when you are using cooking oil, that you're thinking about good ventilation, that you're thinking about maybe using oil less often or using less oil when you do use it. So that's another thing to think about there. And again, all these behaviors in moderation, just try to make small changes. Some other linkages to cancer risks that are more common in AA and NHPI include consuming alcohol. Of course, that's not unique to Asian American population, but still something that we're all aware is a carcinogen and something that we need to be aware of and consume in moderation. Certain infections, H. pylori is more common. Hepatitis B can result in a liver cancer, and it's also something that around 50% of the circulating hepatitis B cases in the U.S. are in Asian American populations. So that's something to be aware of. And then HPV, which can prevent a variety of different cancers, cervical most notably, but also esophageal, anal cancer, and those types of cancers. So that's another one that, and I want to mention as well that hepatitis B and HPV are both vaccine preventable. So if you do not have your vaccine, you should talk to your doctor about whether or not you should do that. And then finally, ingestion of salt-preserved foods. I believe this is something that's more common in Korean populations. It's I think dried fish is known to be carcinogenic. Again, something to think about doing in moderation or finding other ways to do that within reason. But ultimately, we need more data. We need to understand these populations more. And in particular, we need to understand the different subpopulations. We need the data spread out by subpopulation, not just the overall AA and NHPI, because we're really diluting the data when we're looking at, every Asian American is the same cancer risk or the same population. But while we don't have all the data we need, we do know enough to take action. And so this brings me back to my point from the beginning, the social ecological model. Again, thinking about what you can do in the easiest way for you to make an impact is in yourself, and thinking about what you can do. So taking a step and also sharing one step with someone that you know, finding a way to reduce cancer risk in your community. So that is all I have for today. And thank you so much for being here again. Appreciate it.
Thank you so much for that insightful presentation. Help us understand health disparities, community experiences, and why culturally responsive outreach matters. Now we have a brief Q&A session. If you have a question, please raise your hand and our volunteers will assist with the microphone. For a virtual audience, you may put your questions in the chat or text your questions to 626-535-3983.
Yeah. I'll take the one in the back first.
Hello, my question is on the smoking data. Is it also include the vaping part or just tobacco?
I believe it does include vaping as well. Vaping and electronic delivery of nicotine is considered to be part of the tobacco statistics.
So your smoking is including that part as well?
Yes, that's my
understanding. I was
understanding.
surprised the number is still kind of low. I would think it will be a higher number. That's why I want to ask the question.
Yeah.
Thank you.
Yeah, thank you.
不好意思，我可不可以问血液的问题？就是可能血癌啊那种。
Yeah, and if there's any follow-up questions, you can, I guess, direct them to Sophia, and I can try and find data for you if that's something that would be helpful. Happy to do that as well. Yeah, thank you.
We'd like to invite our next speaker and youth MC on stage.
Good afternoon, guys. How are you? Okay. I'm glad to see you guys are actually responding to me. I was expecting a little more dead here, but yeah, good afternoon, guys. My name is Claire Chen. I've been an ACS-YA Youth Ambassador since about 6th grade now. I don't know how much years that is, but you guys can do the math for me, I think. I am here because I've been very passionate about cancer prevention. And you might be asking, why is an environmental studies major so curious about cancer? And well, the simple thing is that our environment is always tied to our health. And so today I'd like to welcome our speaker, Dr. Ting Bao. She is serving as the Deputy Director of the Turing Family Center for Integrative Oncology and the Endowed Director of Research at the City of Hope. And so at the moment, she is researching the safety, efficacy, and mechanisms of acupuncture and yoga. And so her presentation will be about integrative oncology and East-West medicine. So please do give her a round of applause.
Thank you so much. Yeah, really my pleasure to be here. It's actually week 2 of my new job. I just came from Dana-Farber Cancer Institute in Boston. So thanks. It's much warmer here. So truly pleasure to be here to talk about integrative oncology in Eastern and Western medicine for the whole person healing. And this is my background, born and raised in Beijing, China. So I'm actually fluent in Chinese. I can deliver this in Chinese, but yeah, I'm going to stay with English for now. Came to Wellesley College for undergrad, double major in biochemistry and English, and then went to Hopkins for medical school, then became board certified medical oncologist focused on breast cancer. And then always want to bring the best of Eastern and Western medicine together. As a result, got my medical acupuncture training at Health Medical Institute, at that time affiliated with UCLA. And then got recruited to Memorial Sloan Kettering Cancer Center in New York. And basically, was trained to be also integrative medicine physician. So before coming here, I was at Dana-Farber Cancer Institute as the co-director for Zecom Center for Integrative Therapies and Healthy Living. I'm primarily a physician scientist conducting clinical trials. So since fellowship, I have been conducting multiple randomized control trials on different integrative medicine modalities for cancer-related symptoms. So among the 6 pilot studies, 2 maturing now become phase 3 randomized control trial, which I'll mention. And we just recently finished enrollment for Tai Chi CIPN trial. chemo-induced peripheral neuropathy. So my long-term career goal is really to bring the best of Eastern and Western medicine together to integrate complementary therapy into oncology practice to improve patients' quality of life and overall survival. So what is integrative oncology? It's patient-centered, evidence-informed field of comprehensive cancer care that utilize mind-body practices, natural products, and lifestyle modifications from different traditions alongside conventional cancer treatments. This is a definition come together by Society for Integrative Oncology, which is an international organization, multidisciplinary, and our mission is really to advance evidence-based, comprehensive, integrative healthcare to improve the lives of people affected by cancer. If you're interested in joining us, feel free to scan this QR code. I'll wait for a little bit. I am the past president of Society for Integrative Oncology and the current co-chair for research committee at SIO. So when we talk about integrative medicine, it's important to distinguish it from alternative medicine because integrative medicine is used alongside conventional treatment, complementary, whereas alternative medicine is promoted to use instead of conventional treatment. Integrative medicine is evidence-based, non-invasive, relatively inexpensive. Lots of time insurance actually cover, and it's focused on reducing side effects and pain management at this point, whereas alternative is often has this unsubstantiated claims and biologically invasive, often costly. I have patients sitting in my office saying, what do I do? Mexico, there is a 50,000 per month alternative medicine program. So can be very costly. And then usually they claim it's curative. So the reason why it's so important to distinguish this too is because alternative medicine has been shown, observational study, increased risk of death in cancer patients. That's why we try to say we don't practice alternative medicine. And then the major question is how can we bring Eastern and Western medicine together? I believe we really need to incorporate evidence-based complementary therapies. You say it works, then let's do research to show how it works and whether it really works. And so that really requires conduct rigorous clinical research to build evidence. And then we also want to promote this collaborative multidisciplinary care and focus on whole person preventative use. And so one example of this is I'm a breast medical oncologist. So one of the major side effects related to breast cancer treatment is aromatase inhibitor-induced joint muscle pain. And it's up to 50% of patients experience joint muscle pain, and there's no good treatment for that. So even when I was a fellow there, we started conducting different clinical trials. So ultimately, there's 4 pilot, small randomized control trial and 1 large randomized control trial exhibit here. So 226 patients randomizing 2:1 ratio into real acupuncture, sham acupuncture, and usual care. And real acupuncture significantly reduced AI-related joint pain, more so than sham and usual care. Minimum side effects. And because of that, along with the other small randomized control trial, we were able to do systematic review. And ultimately, Society for Integrative Oncology and American Society, ASCO, for clinical oncology, put together a paper, basically a guideline, basically recommending acupuncture should be offered to patients with AI-related joint pain. So with rigorous research, we can change practice. This has become standard of care. And similar thing happened with mindfulness-based intervention, multiple randomized control trial to the point we can do several meta-analysis, systematic review, and ultimately we put together a guideline across the board. Anyone with cancer-related anxiety and depression are recommended to undergo mindfulness-based intervention. And the other modalities may be offered, so more data needed. So going back to my career path, so I started with doing research on acupuncture for aromatase inhibitor-induced joint muscle pain, and then switched my career, actually focus on chemotherapy-induced peripheral neuropathy over the past 17 years. So I'll kind of share what we are have done. So chemotherapy-induced peripheral neuropathy is one of the most common persistent treatment-related complications occurred with those frequently used chemo agents such as platinum, taxane, bortezomib. And common symptoms include pain, tingling, numbness, sensory loss, poor dexterity, gaze disturbance. And the treatment is during chemo, despite all this randomized control trial on different agents approach, right now, people are still just no good treatment, still dose reduction or discontinuation. And then after chemo, there's one drug which I'll mention, and usually it's focused on symptom management with narcotics, antidepressant, anti-epileptics, which has limited effects, potential side effects. So the only one drug actually shows is better than placebo is the L'Occitane. And this is a result on the left, as you can see. So patients with chemo-induced peripheral neuropathy, when they take the L'Occitane, their pain reduced by 1 point on a 0 to 10 point scale. And placebo reduced the pain by 0.3. Around the same time, our team was conducting acupuncture research. The pain reduction was actually bigger, 20 points out on the 0 to 100 point scale, and toxicity is significantly less. So encouraged by that, we ended up conducting a phase 2B 3-arm trial. 75 patients, 25 each, randomized to real versus sham versus usual care. And the idea is to generate prelim data to calculate the sample size for a definitive trial. So this is a study design, like 8 weeks, 10 acupuncture treatment, real sham with its control, then follow up. And this is a result. So basically, real acupuncture significantly reduced the CIPN pain when compared to usual care, and a little bit more so than sham acupuncture, especially at week 12. So that gave us enough data to move on to the next phase. So we received multi-million-dollar grants from NIH because of that to conduct a phase 3 randomized control trial. So we call it ACT, acupuncture for chemotherapy-induced peripheral neuropathy treatment. And then, so randomized 250 patients randomized to electroacupuncture versus sham acupuncture with longer follow-up. We ended up between Memorial Sloan Kettering Cancer Center and Dana-Farber. We finished enrollment in 4.5 years, and now we're actually analyzing the data. So hopefully we'll present it at a major conference pretty soon. And then, because this grant got almost perfect scores from NIH, so we got this additional 2 years funding to study the mechanism. So that's what I'm bringing to City of Hope. So we need to enroll 40 more patients with CIPN pain, randomize them to electro versus sham acupuncture with biomarkers, including functional MRI, skin biopsy, and metabolomics blood draw. And also we continue doing quantitative sensory testing to see if, in addition to subjective measurement and objective measurement, if it's improving as well. So 6 months after we received the grants for ACT, we got another major grant for YCT, yoga for CIPN, and that's based on this phase 2B 2-arm randomized control trial. So 40 patients randomized to yoga versus usual care. They have CIPN symptoms and measure different things, including CIPN symptoms and functional reach test. This is a test we ask patients to reach as far as possible before they feel like they're going to fall. That correlates with the risk of fall. And then the higher the better, immediately separate the curve. So basically the yoga significantly seems to reduce the risk of fall. And as you know, like fall is actually a major risk factor for people's morbidity. And then so 6 months after ACT trial, we got another major grant from NIH, and this time is to study yoga. So over 200 patients randomized to yoga versus education versus usual care in 2:1 ratio with longer follow-up. And then finish enrollment in December last year, analyzing the data, and we're hoping to submit the results to major conference. And both of them may be practice changing, may offer some treatment options for patients with CIPN. So lastly is the Tai Chi for CIPN. As we know, especially like dear to our heart, Asian culture, Tai Chi is a traditional mind-body intervention, involves gentle body movement, meditation, breathing technique, and it has been shown to improve balance in patients with Parkinson's, knee osteoarthritis. So can it help CIPN? So we received a pilot grant from Harvard Medical School, Osher Center, and then a small grant. So we have 21 patients randomizing 2-to-1 ratio to Tai Chi versus usual care. And because the sort of pathway we established at Dana-Farber, we were able to enroll all 23 patients within 4 weeks. So just one cohort. So by this time, I think at the end of this month, we're going to finish collecting all the data and we'll be able to present. So that should give you a taste of what kind of research we're doing. And so Churn Center is started 3 years ago, thanks to the general donation from Churn family. It's actually the first ever biggest donation in the country, in the world, is $100 million. So it started 3 years ago, and our center has been really the most fast growing center ever. So our goal is really integrate Eastern and Western medicine approach. And we have multiple different kind of healing practice we're offering to patients, and we're studying them. And our care is evidence-based, whole person focused, culturally balanced. Right now, we're offering it at Duarte campus, Orange County campus, and as you know, City of Hope has 3 other campuses. We all offering those. And our goal is to treat the whole person, not just the disease. And we really want to bridge the ancient healing wisdom with Western medicine innovation. And through rigorous research, that's why I was recruited here. And the goal is to continue conducting rigorous research to find evidence and to change practice, make integrative oncology part of the standard care, not just only complementary. And also we continue to offer like clinical care and education. So it takes a village, like all these people, there's actually more I need to list here, and multiple fundings to reach this point, with special thanks to our patients. Over 600 patients really helped to make all this possible. If you're interested in learn more, so join us at the Society for Integrative Oncology Conference in Detroit this year, September 29th to October 1st. Our theme is cultivating community and belonging in integrative oncology. Thank you. Yeah, happy to take some questions. Thanks.
Thank you, Dr. Pao, for your insights into integrative oncology. Let's open the floor to Q&A. Once again, if you have a question, please raise your hand and our volunteers will assist with the microphone. For virtual audience, you may put your questions in the chat or text your questions to 626-535-3983.
Data, other data, kind of validated. But couldn't we draw that data out of Asia? Don't they have their own data, or we could start all over again?
No. We work together with them, actually. Yeah, we have, in fact, last year, I missed that. We did, the center actually went to Asia and talked to all these major oncology center, like integrative medicine centers in Asia. Every 2 years, we're doing that. And I came from Beijing, so I go there like 1 to 3 times per year, and then I already have all this connection. So lots of time, like even the acupuncture protocol and stuff, I consulted those traditional Chinese medicine doctor. We don't do it on our own, and yeah, we actually learn from them. Yeah, and then together we want to collaborate. Yeah. Love to. Actually, Chern family is really into like herbal medicine as well. So we're definitely slowly and surely like looking into it. Yeah. Yeah. When I was a medical school student at Hopkins, I really wanted to do herbal medicine research, but then honestly, it's just so hard. So I ended up starting with acupuncture. It's just so much more accepted, right? Yeah. And easier to standardize. And then, when I was in China, I always like drink Balangan when I was sick. So I always want to learn more and then study more. So I think timing is right too. Yeah. Yeah, thank you. I'm catching a flight, but yeah. So email Sophia, and then I'm happy to connect with you, answer your question. Thank you. Thank you.
We will now transition to our next speaker.
Good afternoon, everyone. My name is Elizabeth Chen, and I am a freshman at Polytechnic School in Pasadena. This is my first year in ACS-YA, and today I will be one of your youth MCs. Now, are we ready to meet someone who makes the word busy feel like it needs a calendar, a backup calendar, and possibly a legal team to manage it? It is my pleasure to welcome Dr. Christine M. Lovely from City of Hope. Dr. Lovely is Division Chief of Thoracic Medical Oncology and Professor of Medical Oncology at City of Hope. Now, while most of us are dealing with double book schedules or unread emails we are emotionally avoiding, she is advancing lung cancer research and helping shape national treatment standards. She previously held a tenured faculty role at Vanderbilt University Medical Center and is nationally recognized for lung cancer research. She serves on the AACR Board of Directors and contributes to NCCN guidelines for lung cancer care. What stands out most is her ability to turn complex science into real patient impact. In medicine, progress is measured in breakthroughs, but is powered by people who never stops asking what comes next. Please join me in welcoming Dr. Christine M. Lovely.
Well, thank you so much for that kind invitation and kind introduction. I am so impressed by the audience that is here today on this beautiful Saturday on a holiday weekend. And it is my pleasure to talk about lung cancer today. And where is the slide advancer? Oh, just fine. So my name is Christine Lovely. I am the Division Chief for Lung Cancer Medicine across the City of Hope network. I will start by saying I just arrived in California about 4.5 months ago. I practice in Duarte. I live in Arcadia. I just came from Nashville, Tennessee, where I worked at Vanderbilt for 20 years, and I grew up in the suburbs of New York City. So it is a pleasure to be here with you all now in California. Okay. Bear with us 1 minute. Sorry, a little technical error. Talk amongst yourselves. Sorry, everyone.
Why? Why?
There it is. Yeah. Okay, we're back on, everyone. Thank you for your patience. Okay, so going back to, I just arrived in California about 4.5 months ago, and I was in Nashville for 20 years. So I will start by saying, one of the reasons I moved after so long was because I'm so impressed by the resources that are available at City of Hope and by the amazing community that is here to support all cancer patients and their families. And I think really what we're seeing today in this amazing community is people really care about how to make cancer treatments better. And that is really the vibe and the love and the passion of everyone at City of Hope. So today I'm going to talk about my love, which is lung cancer. And I've been a lung cancer doctor for 20 years, and it has changed amazingly over that time. And there's a couple of high-level things that I would like to talk about. And I will start by saying there is absolutely no way that we can talk about all of lung cancer in 15 to 20 minutes. But if you have any questions, I would be happy to take them during our question and answer time or afterwards. Please come find me. I would like to talk about screening and early detection. This is so incredibly important. We want to find cancers, any cancer, as early as possible so we can treat it for cure. I want to talk about new medicines that we have for lung cancer to help us treat lung cancer better, faster, and get that cure. I am a medical oncologist. I am the type of doctor that uses medicines to treat lung cancer, and I'm going to talk to you about some of those medicines. I'm going to be honest and talk to you about some of the barriers to lung cancer, because lung cancer has been a huge challenge, not just here in California, but across the entire United States and across the entire world. But I'm going to end with a message of hope on the horizon, because it has changed incredibly over the past 20 years that I've been a lung cancer doctor, and it will continue to change incredibly over the next year, even over the next 5 years and after the next 10 years. But we need to partner together in order to do that. We're going to talk about some of that hope on the horizon. So let's start by talking about the state of lung cancer. And you heard a little bit about this, but I want to talk about some specifics. Here's the sobering message. Lung cancer remains the #1 cause of deaths related to cancer in the United States and worldwide. It has been the #1 cause of cancer-related deaths for decades. About 1 in 5 deaths across the globe is from lung cancer. That is a staggering number. More than 1 million people die from lung cancer every year. That tells you how much work we have to do to help patients and their families with lung cancer. And even more so, and I treat lung cancer patients, about half the patients that I see with lung cancer are diagnosed at a time when their cancer has already spread outside their lungs. And at that time, I have to have a conversation with the patient that we cannot cure your disease. We can treat it, but we can't cure it. That is why we're going to talk about the importance of screening and how we try to capture lung cancer earlier, because it is so incredibly important to think about finding any cancer, especially lung cancer, as early as possible. Let's talk about some specifics again. And I want to really drill this message home because I'm going to be honest too. Part of the barrier to lung cancer progress has been that lung cancer has been stigmatized for years. People think that all lung cancer is related to smoking, and there is shame and blame related to that. Let's put that aside. Especially here in Southern California, almost all the patients that I see with lung cancer have never smoked. That is true. And so yes, there is a component of lung cancer related to smoking. We do not blame people for that. We help them. And there is a huge population of patients who have never smoked to get lung cancer. And I'll be honest with you, we don't fully understand the reasons why, but we need to do better in trying to understand. Despite that, despite all of the reasons for many causes of lung cancer, if you look again, the number of lung cancer deaths every year, smoking related, not smoking related, outpaces the other top 3 cancers, colon, breast, and prostate combined. And I share this information with you so you can understand my passion for wanting to help lung cancer, the lung cancer community. It's a huge problem that we need to address, and we do so as a community. Let's think about specifics here to California. And these are data from the American Lung Association. And you can all look this up. This is actually, the website is on the bottom of this slide. If we think about the number of cases of lung cancer every single year, the green bar in the middle is the average. This is all 50 states in the United States. So California is actually on the low end of lung cancer, number of lung cancer cases in the United States. I just came from somewhere, Tennessee, which is a smaller state than California, but has a huge number of lung cancer cases because it's historically in what we call the tobacco belt of the United States. California, however, does better than most states in terms of survival from lung cancer. So if you look, the green bar in the middle is the average survival from lung cancer, and California is towards the top end. So that doesn't mean that we don't have work to do, but if we just look at statistics and we say, where is the environment in which we're living? Here's where California is actually doing well. It ranks 10th among 39 states with survival data above average for how lung cancer patients tend to do. But here's where we're failing, or here's where we're not doing well. We are not implementing screening. So California is below average in terms of implementing lung cancer screening. We need to do better. So the green bar in the middle is average. California is below average in lung cancer screening. And here, California is way above average in actually getting lung cancer patients treatment. So the green bar in the middle is the average number of patients who get lung cancer treatment across the United States. And you see California's above, way towards the right end. Patients in California sometimes don't get treatment for their lung cancer. So we need to do much, much better there. How do we make a difference for lung cancer patients and their families? Let's think about where we are with lung cancer today. And I'm going to say there's huge progress, huge challenges, but unprecedented hope. What does this look like? What has changed? I just told you some very sobering statistics. I'll balance that with remarkable progress. I'm going to talk about some progress in precision medicine, personalized care, what we call biomarkers for lung cancer, immunotherapy for lung cancer, new treatments that actually activate the immune system to fight the lung cancer, earlier detection and screening, multidisciplinary care, meaning you see multiple doctors to help you treat your lung cancer. The current reality, though, is lung cancer is still the leading cause of cancer-related deaths in the United States. We have disparities in care. We have the stigma associated with lung cancer, whether you're a smoker or a never smoker. And we have too many patients being diagnosed at advanced stages. But there's hope on the horizon and huge turning points, rapid innovations in new therapies, expanding clinical trials, and a huge message I want to send, and what I'll end with is research pushes new treatments and new cures. We have survivorship and better quality of life. And I love the previous talk on integrated medicine because we need multiple different ways to think about how we best take care of patients. And we need collaboration across all sorts of doctors and care teams to really push treatments for lung cancer patients. Let's talk about screening. What is lung cancer screening? Many people in this room may not even be aware that we have lung cancer screening. Here's what lung cancer screening is. So this thing that looks like a donut is a CT scanner. Lung cancer screening is when a patient goes through a CT scanner. It takes about 15 minutes or so, but the scan itself takes about 3 minutes. It uses high-dose X-rays, but very low-dose radiation to get a picture of your lungs. There is no contrast. You don't need to have an IV. It's pretty fast, and it's performed without any needle. So it's just in the machine, out. You kind of go through that donut part. So who is eligible for lung cancer screening? This is very different than other types of screening like mammograms for women where all women are eligible at a certain age, or colonoscopies where all men and women are eligible at a certain age. There are criteria for lung cancer screening, and the criteria from something called the United States Services Preventative Task Force are lung cancer screening becomes available, oops, that wasn't meant to change, for patients age 50 to 80 who have what's called a 20-pack year history of smoking. 20-pack years means, for example, smoked 1 pack a day for 20 years. That's a pretty constricted eligibility criteria if you think about it. So if you've never smoked cigarettes, you will not be eligible for lung cancer screening. If you smoked in college, you will not be eligible for lung cancer screening. But this is what we have for lung cancer screening right now, and it is incredibly important. It saves lives to detect lung cancer earlier. We are working very hard in building better tools for lung cancer screening. And this is one of my colleagues from Harvard. Her name is Leisha Sequist. She is building AI tools to help us screen earlier, do better for understanding lung cancer detection and nodules on CT scans. So we could talk an hour or more just about screening and early detection. But I want you to hear is we have lung cancer screening. It's not for everyone. It's not for never smokers, which is the majority of patients I see in California. And we're making better tools for lung cancer screening. The goal of lung cancer screening, and this is incredibly important, is to find the lung cancer early in at-risk individuals and increase the chance of cure. What does cure look like? For early stage lung cancers, we want to get the lung cancer out. For most cancers, the best treatment you can have does actually not involve me. I am the doctor who gives the medicine like chemotherapy, immunotherapy, targeted therapy. We want to take it out with a surgery or zap it with radiation. So early stage lung cancer typically involves surgery or radiation to literally remove the cancer. And the earlier we find it, we can physically take it out of your body. That improves your chance of the cancer never coming back again. Let's talk about the treatments that are in my realm as a medical oncologist. And there are literally thousands of new treatments that have come into play for lung cancer, and it is exploding. And we're about to have next week the biggest cancer conference in the world. If you're interested, look on the news for something called ASCO, ASCO, American Society of Clinical Oncology. It is the biggest cancer conference in the world, and all of the new cancer treatments, there's going to be major advances. You're going to see it on CNN for lung cancer, pancreas cancer, breast cancer. Let's talk about some of the new treatments for lung cancer. To explain the new treatments for lung cancer, I have to tell you about the different types of lung cancer. And there are 2 major types of lung cancer. And it's based on how the cancer looks under the microscope. One is called non-small cell lung cancer. That's the majority. That's about 90% of all lung cancers. The other is called small cell lung cancer. That's the more aggressive type of lung cancer, almost exclusively related to prior smoking history, not always, but usually, and is much less common than non-small cell lung cancer. We usually think about, and you heard in the previous talk, chemotherapy as a treatment for cancer. Let me be very clear and say that is one tool we have in our toolbox, but is not the only tool. In fact, it is more often than not that I'm using other tools to treat lung cancer. And those other tools are what we call targeted therapies and immunotherapy. They are not chemotherapies. Let me explain. Targeted therapy is where we understand the blueprints, the map of the cancer, what we call in medical terms, the DNA of the tumor. And we use that understanding of the DNA of the tumor to help direct personalized, precision-based care. If I understand what is driving the cancer to grow, I can give a more personalized treatment for an individual. Because there's 100 people in this room, and if you all had lung cancer, and I hope I never see you in my clinic, but you would need an individualized care plan, and that's the idea of targeted therapies. The idea of immunotherapy, on the other hand, is to activate your own body's immune system to fight the cancer. Because you're not supposed to have a cancer in you. A cancer was once your normal body that has become a tumor. And your body should be able to get rid of it. And the immunotherapy is to help your body, your own immune system, to recognize the cancer as foreign and get rid of it. What is personalized care for cancer medicine? And this is part of the daily practice of lung cancer. And this is such a huge, important topic, and lung cancer leads the field here. I'm going to explain this, and we could talk again for hours and hours about how precise we get in our care in lung cancer. When a patient sees me in clinic, we take a piece of their tumor, a biopsy or a surgical specimen. We look at that tumor underneath the microscope. We do all sorts of tests. We look at the map of the tumor, the DNA. We try to understand what is making the tumor become a tumor. And then we use that information to individualize care for our patients. And when you come into clinic, we actually get this very complex set of information. These are all of the markers and more that I'm looking at in my lung cancer patients when I see them. And all of these markers help me to understand, how do I give the most precise, most personalized care plan for my patients? So this is part of the standard of care for patients with lung cancer. And each of these different markers is tagged to a different drug or set of drugs that we use in lung cancer care in 2026. Now you could say, does this matter? You do all this testing, does it actually help you? And I think these are what we call biomarkers. You'll hear mutations, you'll hear personalized care. They're all synonyms for the same thing. Make the care more personalized. Does it matter? Let me show you an example. This is an example of a success from biomarker-driven care in lung cancer. This is a type of lung cancer called ALK-positive lung cancer. This is an example of patients with stage 4 lung cancer. They all have ALK-positive lung cancer, so they all have this ALK biomarker in their tumor, and they get 2 different ALK drugs. So one of them is called crizotinib, and the other one is called lorlatinib. The name of the drugs is not important. What I want you to see here is we have biomarkers that help us direct our care, because you only get the ALK drug if you have the ALK biomarker in your tumor. And when we get an understanding of the molecular basis, the genetic basis of the tumor, we make better treatments and we get better outcomes for our patients. Let me show you. This is probably the most remarkable curve that is in lung cancer right now. Let me explain further. On the y-axis of this, or x-axis of this graph on the bottom, is the time. And this is time in months. And so this is almost 7 years on the bottom of this graph. And on the y-axis is something we call progression-free survival. That translates into when a patient starts a drug and when they start and when the tumor starts to grow back again. The take-home message here is when patients with ALK-positive lung cancer, that specific biomarker in their tumor, when they go on the ALK drug lorlatinib, they stay on the ALK drug, that one drug, which is a pill they take 1 time a day for more than 5 years. And these are all patients with stage 4 lung cancer. That's amazing. To have a patient with stage 4 lung cancer on one pill once a day for more than 5 years. That is only possible when you understand the genetic makeup of the tumor. And this is how we treat lung cancer now. I want to mention one other mutation, which is extremely, extremely, extremely important, particularly in Asian populations. And honestly, is one of the major reasons I came to City of Hope as well, because in addition to being a doctor who sees patients in clinic, I also run a research laboratory. And this is something that I have studied for many years. There's a particular mutation called EGFR. Here's something I want you to all put in your mind. EGFR stands for epidermal growth factor receptor. It is one of the most common mutations in lung cancer, and it is extremely common in patients of Asian ancestry who've never smoked. And there is tremendous research going on across the world to understand, why does this mutation happen? How do we make better drugs? You might have heard of a drug called Tagrisso. This is an EGFR pill that we use to treat EGFR mutant lung cancer. And if you know anyone who has this kind of lung cancer, we'd be happy to talk to them here at City of Hope. This is an incredibly active area of research and a very, very, very important area, especially for the Asian community. So I'm going to end with, we're seeing remarkable progress, but there's some barriers too, and I'm going to ask for everyone's help in this room. I want to come back to, remember, lung cancer, #1 cause of cancer-related deaths in the United States. And I'm about to finish, so my time is up. I'm going to say barriers. We have lung cancer screening for patients who have a history of smoking. We don't use it to the extent that we should. There is no screening for never smokers. So a lot of patients that I see here would not be eligible for screening. And one other important message is lung cancer is underfunded compared to other cancers. And so if you just look at numbers and statistics, lung cancer historically has received less federal funding than the other big cancers like breast cancer, prostate cancer, colon cancer. So even though it's very common, it's understudied relative to other cancers. Huge progress, huge momentum for lung cancer, all sorts of things, new medicines, clinical trials, new technology, something called liquid biopsy that we don't have time to get into, AI for nodule detection, for everything. What does this turn into? Clinical trials is how we make new medicines, how we make advances. Please, if you know anyone who has cancer, think about clinical trials. Think about going to a center like City of Hope, like other centers in town that have experimental treatments that can advance treatment cures. We will make huge impacts in the next 5 years, thinking about at-risk individuals, better screening and early detection, better diagnostic evaluations, better treatments, and very importantly, if you have a lung cancer diagnosis, how do you survive with it? Whether you're on drug or you've had a surgery, that plays into the previous talk too. We want to make sure patients live and live well with their cancer diagnosis. And I'm going to go through all this. And I'm going to end with one last slide. There is no way we could possibly go through every single treatment that exists right now for lung cancer, because there's immunotherapies, there's targeted therapies, there's something called antibody drug conjugates, so much. Every treatment that you hear about for cancer, lung cancer is my passion. Every treatment, whether it's pancreas cancer, breast cancer, exists today because a patient chose hope over fear and participated in research and helped us to all learn. This is incredibly important. For me, because I love lung cancer, I'm going to say the story of lung cancer is still being written. Patients and caregivers are just part of the story, but they're incredibly important part. You are all helping to lead that, and we thank you for being here today, and I thank you for your time. I would be happy to take any questions. Yes, in the back. Yeah. Correct. Correct. Yeah, so this is another reason I came to City of Hope, because this is a huge problem. Because number one, there's a difference between prevention and screening. Prevention means we try to prevent a cancer from ever happening. That is the goal for every cancer. We don't want any cancers. Screening is, how do we identify a cancer early? For lung cancer screening in particular, the screening that we have right now, the low-dose CT scan is called, is only for patients who are age 50 to 80 who have a 20-pack year history of smoking. If you're confused, you should be, because it's confusing even to healthcare professionals, and that's part of the reason that it doesn't get implemented. So even patients who are eligible for screening are not getting screened. So number one message is, if you yourself or anybody you know has a history, any history of smoking, tell them to talk to their doctor. Are they eligible for lung cancer screening? That's the most important, part of the important question here. If you know anyone, whether any history of smoking, tell them to ask their doctor, am I eligible for lung cancer screening? The other side of this coin is there's a huge population of lung cancer patients who are not even eligible for lung cancer screening in our current guidelines. So what do we do about that? It's a massive problem. In Asia, they actually do low-dose screening CTs for people who have family histories of cancer, for example. We don't have that in the United States yet. And it's complicated. It's related to actually building research studies. It's related to insurance. It's related to how do we develop the best practices for implementation. This is actually something I really want to bring to City of Hope because there have been studies outside of the US that say, if you're an Asian female never smoker and you're at higher risk for lung cancer, you should get CT screening. We just don't have that yet in the United States. Huge knowledge gap. You hit the nail on the head. We desperately need ways to think about how do we screen for lung cancer in patients who are not eligible from the current USPSTF screen guidelines, which are pretty restrictive. Yeah. Mm-hmm. Yeah. Yeah. No, yeah. So it's interesting because, lung cancer is not one thing. It's many, many different diseases. It's just lumped into lung cancer. And so lung cancer in never smokers tends to do better than lung cancer in heavy smokers because lung cancer in heavy smokers often comes with other medical conditions like COPD, emphysema, heart disease, vascular disease. And so more disease burden, the lung cancer is just part of the collective that goes along with smoking. Mm-hmm.
California treatment's better than what's just in Mexico or Tennessee or?
No, because there's disparities along every part of the journey. Everything, income, environment, pollution, healthcare access, type of insurance you have, how you access care, language barriers. It is a case history for how do we actually deliver care. And something I will tell you I feel very, very strongly about. We cannot just say we have research to develop new treatments because it's not enough to just develop a new treatment. We have to make sure that everyone everywhere has access to that new treatment. Yeah. Yes. Thank you. Yeah. Yeah. Yes. Yes. Yes, this is a very good question. And I'm like, oh, okay. I live here now too. So what are we going to do about this? This is a major problem. I don't have a good answer to this. I think number one is masks when the wildfires is around. I think that's the minimum we can do. HEPA filters in your house for air if you're close by a fire. I think this is something, honestly, that the state needs to put more research around. I can't, this is a long answer to the question, but I'm going to make reference to when I was in Vanderbilt, I also had an affiliation with the Veterans Hospital, and we cared for patients who were in the Army who had exposure to things like burn pits. And we knew that those veterans had increased risks of lung cancer because they were exposed to burn pits. We need similar studies here in the state of California because we all are exposed to fire. And I can't believe that the inhalation risk over time is not going to be somehow related to injury to your lungs. And injury to your lungs sets up things that can happen in your lungs that maybe cancer is a risk factor. We have to study it. Yes. All right. Thank you all so much.
It is now our great honor to welcome Congresswoman Judy Chu to share a few words with us. Congresswoman Chu has been a strong advocate for our communities, and we are deeply grateful for her continued support of community health, youth leadership, and cancer prevention efforts. Today, she will also help present certificates of appreciation to recognize our dedicated volunteers and organizers whose hard work made this symposium possible.
Please join us in giving a warm welcome to Congresswoman Judy Chu.
Well, hello, everybody. I'm Congressmember Judy Chu, and I'm thrilled to be joining you for this 2026 Asian American Cancer and Diabetes Health Symposium. I especially want to thank your Lions Club International Past Council Chair, Roger Powell, Symposium Event Chair, Sophia Young, your American Cancer Society President, Scarlett Yu, and City of Hope's Cancer Care Director, Dr. Kim Lynn Ashing, along with your entire team for making this event possible. Events like today are crucial because certain cancers disproportionately affect the Asian American, Native Hawaiian, Pacific Islander, or AANHPI community. Though Asian Americans make up 7% of the US population, they account for 60% of the chronic hepatitis B cases and have double the rates of stomach cancer compared to white Americans. Language, culture, and geographic barriers limit access to quality healthcare, with 32% of AANHPIs having limited English proficient skills, making life-saving information harder to access. And that's why I have worked on these particular diseases. Last year, I partnered with Representative Joe Wilson to introduce the Stomach Cancer Prevention and Early Detection Act. Stomach cancer has been disproportionately common in veterans and AANHPI communities. And in fact, for Korean, Japanese, Chinese, and Vietnamese Americans, they have a 3 to 5 times higher stomach cancer rate. And yet, if caught in the early stages, it is quite preventable. Our bill calls on the National Cancer Institute to conduct a full review of stomach cancers in the United States, from risk factors to the accessibility of screenings. It also directs the Department of Defense and the VA to ensure that military service members and veterans are able to access these life-saving prevention tools. And then there is liver cancer. And one of the greatest contributors to this, which is hepatitis B and C. This issue hits our San Gabriel Valley very closely. And in fact, there is the devastating effect of hepatitis B that was evident in the life of a friend, Chi Moy, who was a longtime community activist and then was able to get elected to the San Gabriel City Council. When he was donating blood, he found that he had hepatitis B. And we watched him get weaker and weaker until he was able to become the first Asian American mayor of San Gabriel. But 1 month later, he died from liver cancer. Similarly, my sister-in-law battled hepatitis C for years before it developed into liver cancer. But the thing is that there are abilities to combat this, and that's why so much more research needs to be done. And yet both hepatitis B and C are responsible for over 65% of liver cancer cases. This is why I was so upset when Health and Human Services Secretary Robert F. Kennedy Jr. removed the mandatory vaccination of all newborns earlier this year. This vaccination has saved so many lives. So at a Ways and Means hearing in Washington, D.C., I was able to confront Secretary Kennedy at a hearing and confronted him on why he did this. He did not have a good answer, I must say. But there is an important step that I was able to get going, and that is I requested that the GAO, or General Accountability Office, do a study and report on the effects of the removal of this newborn vaccination. They agreed to do it, and the report will come out in a few months. So we will know the real results of this. Let me say, I am so grateful for this symposium. Because of your work, people from all around the San Gabriel Valley will hear from experts that will provide insights on cancer, diabetes, and mental health while discussing advances in cancer care and diabetes research. And the best part is that all the information provided today will be available in Mandarin, Vietnamese, Korean, Japanese, and Hindi, which will ensure that all our AA and HPI communities can take advantage of these resources. So thank you again to the Lions Club, American Cancer Society, City of Hope, and all the volunteers for the hard work for this amazing symposium. And so I would like to present certificates of congressional recognition for those who made this possible. Scarlett Koo, President of the American Cancer Society. Ling Wu, Honorable Chair of the American Cancer Society. Virginia Huang, Honorable Chair of the American Cancer Society. Maggie Lee, Honorable Chair of the American Cancer Society. Sophia Young, Symposium Event Chair. Angel Pei, District Governor of the Lions Club International. Teresa Chen, Volunteer Chair. Dr. Kim-Lin Ashing, Director of City Hope C-Care. Safa Mohammed, Symposium Event Vice Chair. YA Leader, Claire Chan of the American Cancer Society. YA Leader, Angela Unayan of the American Cancer Society. Angela Unayan. Congratulations all.
Okay, so again, Angel, Teresa Chan, Kimberly Claire Chan, and Angela. Yeah, 1, 2, 3. Very nice. Thank you. We want to take a picture with all our guests. So back tip. Yes, turn around. Yes, well, let me come down here. Okay, right here. 1, 2, 3, cheese. This is the doctor's camera. Okay. All righty. I think this one's good. Yeah, let's see.
Yeah, I want to present our first Vice District Governor and Jenny Huang come to the stage and present the check to the director.
Are we? We need to change the slides.
Go ahead then. 1 second. I think we should have stayed because we're going to have to go through multiple presentations. Okay. Presentation.
Really excellent.
We would now like to invite Dr. Buddy and Wesley to the stage.
Hello, everyone. My name is Wesley Buddy. I'm currently a sophomore at California School of the Arts in Duarte, and this is my first time being part of the ACS-YA program. I would like to now introduce Dr. Buddy. Dr. Elizabeth Buddy is a hematologist, oncologist, and physician scientist at City of Hope, serving as Associate Professor in Hematology and Executive Medical Director of the Enterprise Immune Effector Cell Program. She serves on several national committees, including the NCCN Guidelines for B-cell lymphoma, NCCN Guidelines for the Management of Immunotherapy-Related Toxicities, and the Cellular Therapy Initiative Committee of the Alliance of American Cancer Institutes. Dr. Buddy has received numerous honors and awards. She was a recipient of the prestigious Damon Ryan Clinical Investigator Award and was named Researcher of the Month in April 2025 by the Medical Oncology Association of Southern California. She has published more than 100 papers in leading peer-reviewed journals. As a lead investigator, she led the FDA approval of the first bispecific antibody for lymphoma. She is the principal investigator of innovative translational research protocols and maintains a dynamic portfolio of clinical trials in a research laboratory with the focus on advancing immunotherapies, including engineering and designing CAR T-cell therapies. Now, please join me in welcoming Dr. Elizabeth Buddy to the stage.
Well, thank you for that very kind introduction, especially, hearing your son introduce you is such a great honor. So today I'm giving the task to talk about breakthroughs in blood cancer care from immunotherapy to hope. So it's a pretty big topic. So I think what I will do is maybe I'll start with just talk a little bit about immune system immunotherapy, and then we'll go and talk about immunotherapies in blood cancer. So our immune system, as you can see here, is really composed of many various types of cells and organs. It's a very complicated network, and together they function for three major events in our lives. They function to fight off the infection. I think most people know that part, and they also function to recognize and remove the toxic substance from the environment. Last but not the least, very relevant to today's topic is immune cells are also the main players that help us to recognize and eliminate cancer cells before they have a chance to develop into cancer. So when immune system works, we don't really feel it because we feel good. We don't have any symptoms, right? But when immune system doesn't work, when we have infection, we have symptoms. Those symptoms are really a reflection of the fight between our immune cells and the infection. And similarly, when in the body, there are abnormal cells that developed. When these abnormal cells have found a way to get around our immune system surveillance, then develop into cancer, then we will develop symptoms or signs from the cancer. So I put in here three scenarios that our body might allow cancer to develop. On the far right over there is a scenario. So we have healthy T cells. But there are also abnormal cancer cells. And these healthy T cells, unfortunately, they cannot recognize these tumor cells. So therefore, the tumor cell continue to grow and become a problem. And in the center is there are tumor-specific T cells in our body, but they're outnumbered by these cancer cells. And these cancer cells, somehow they have an advantage. They either acquire some sort of mutation or they have growth advantage. They continue to grow and outnumber the tumor-specific T cells, so they are the winner. So the third scenario is we have tumor-specific T cells there in our body, and they are cancer cells, tumor cells. But these T cells, they are very exhausted or they're dysfunction. They can recognize the tumor cells, but they don't really function. They don't work. So all this scenario leads to the end result is cancer will grow. So then what's cancer immunotherapy? Cancer immunotherapy is really a way to allow us to harness the body's immune system to identify and eliminate cancer cells. Very different than chemotherapy, which shown in the middle here. Chemotherapy or radiation, they really cannot differentiate healthy cells or from cancer cells. So when you get chemotherapy treatment, the chemotherapy will get rid of cancer cells, but at the same time will also damage the body. Therefore, there are many, many side effects. Some of them are long-term side effects associated with chemotherapy. In contrast, for immunotherapy, we want it to be specific, target specific. We want the immune cells to be able to recognize and use our own immune system power to get rid of cancer cells. So therefore, it's a very powerful and specific. And in general, immunotherapy will have much less side effects than chemotherapy. So coming to the evolution of blood cancer treatments, this is really similar to other type of cancers. The first chemotherapy treatment for all cancer actually started in 1940s. And this, I'm not sure any chemistry genius down here if you can recognize this molecule. So this is nitrogen mustard. So this was actually, it's an alkylator and used as a fertilizer that kills off the pathogens, also kills off human cells. So this is the first ever chemotherapy agent that was used in a patient with later turned out to be T-cell lymphoma. So that's how we began to use chemo drugs to treat cancer, and it happened to be a lymphoma patient. And after this one, there are many different chemotherapy drugs were developed. The latest one was bendamustine back in 2008. But since then, we're not really developing more chemo drugs because we know a lot more about immune system. Because the advancing science, we know a lot more about how immune system recognize tumor cells and how a tumor cell become a tumor cells, how they dodge the immunotherapy treatment. So basically, it is a fight between the immune cells and the tumor cells, and how do we overcome that? So since 1997, which is really 50 plus more years since the initial development of a chemotherapy, finally the first antibodies were FDA approved. This is rituximab for patients with B-cell lymphoma. It recognizes the CD20. It has pretty modest activity. It's just a naked antibody, but it's mimicking our body's own good immunoglobulin. So it was approved in 1997. And a few years later, the first ADC, which is called antibody drug conjugate, the first one is the brentuximab. So what it is a naked antibody, but it's tagged to a toxin or a chemo payload. So we also call it, an antibody with a warhead. So basically, the antibody will bring the warhead to the cancer cell with the target, and then dump the warhead, or the toxin to the cancer cells, and then kill it off. So this is called antibody drug conjugate. And in 2014, which is the first actually pure immune therapy was developed. This is a first generation blinatumomab. So it's a bispecific T-cell engager. So basically, this very small molecule gets infused into your body. This is in the patient with leukemia. It brings together your T cells, your immune T cells, which are very powerful, and also bring it to the tumor cells. And then the immune T cell, once activated, you'll be able to get rid of the leukemia cells. Itself doesn't really have any activity. It has to be in the context of bringing those two together. So in 2016, another major breakthrough is the approval of the first checkpoint inhibitor. So this is really trying to remove the brake so your immune system will be able to continue to function and work to reinvigorate and get rid of the tumor cells negative signal. And in 2017, sorry, it's blocked. But 2017, a really major breakthrough that had really revolutionized how we manage blood cancer was the CAR T cells for patients with blood cancer. This is taking the immune cells out of your body and modify them and engineer them to tumor specific T cells, and then expand them and then infuse back to the patient. So it's a cell therapy, it's a gene therapy, it's also immunotherapy. So now let's just talk a little bit on this immune inhibitory checkpoint modulation, the PD-1 blockade. So this is really based on the seminal discovery of the PD-1 molecules, which is on the surface of these immune cells. And so basically, when the immune cells recognize the cancer cell, via the T cell receptor, that's the green part. So you will reach out to the cancer cell, engage the cancer cells. In a normal condition, this immune cell will be able to kill off the cancer cells. But cancer cells, some of them are pretty smart. So they will upregulate a PD-L1, that's the pink molecule there, which grabs the PD-1 on the surface of immune cells. So this is like, it's like putting a brake on T cells function. And this made the T cells fall asleep. So basically made the cancer cells and the immune cells in harmony, which is we don't want, right? So in 2018, so the discovery of PD-1 or PD-L1 inhibitor, basically this small molecule, antibody-based molecule, was able to disrupt the communication between the cancer cell and the immune cell. So that way, then the immune cell will be able to be reinvigorated and be able to recognize cancer cells and eliminate it, complete the job. So this actually won the 2018 Nobel Prize in Physics or Medicine. So how does it work in the clinic? So this is a patient that I had back in 2016. So this is usually for Hodgkin's lymphoma with chemotherapy treatment, we're able to cure around 80% of patients. But there's still 20% of patients whose lymphoma just so refractory to chemotherapy treatment. Now, this patient had ABVD 10-6 cycles, didn't work, had RICE, 10-4 cycles, also didn't work. Then the patient referred to City of Hope, and at the time, we have a clinical trial testing the pembrolizumab, which is a PD-1 inhibitor. That small molecule can really break the interaction between the tumor and the immune T cells. So she was enrolled on the study, received this infusion every 3 weeks. Now, after 4 cycles, now she went into complete remission. Can see from June 2016 to October 2016. We think less than 4 months, she went into a complete remission, and then we took her to autologous stem cell transplant as consolidation, and she has continued to remain in complete remission ever since then. So it's been 10 years now. And similarly, many other patients enrolled on the studies that has also responded to to this treatment. Therefore, it received the FDA approval in 2016.
So next, I'm going to actually spend the remainder of my time talking about something very exciting, really powerful T-cell-based immunotherapy, so target-specific T-cell immunotherapy. So unlike the PD-1 we talked about earlier, it's not target-specific, so it activates the immune system globally. But now we can do it more specifically. Only part of the T-cell will be activated, spare other T-cells. So basically what we want to do is really to harness the power of T immune cell, immune killer cells, to recognize and get rid of the cancer or really bad cells. So basically, you have a T-cell with an ordinary T-cell, which doesn't recognize the cancer cell, so the cancer cell has the upper hand. Then there's a way we can really transform the ordinary T-cell into a super T-cell. And these super T-cells are target specific. So you can recognize the cancer cells and just knock it out. And at the same time, you can clone yourself because it's a living drug. The cell-based therapies get in the body and they can actually travel to the parts of the bodies that the bloodstream will not be able to take the drug to. So it has high potency, can travel to the central places, and it's a living drug. In the best case scenario, you can actually clone yourself by 1,000 times. So one of the major T-cell based immunotherapy is this bispecific antibody. So what it does now, if you look at that, it's a Y shape, is the bispecific antibody. It's it looks like an antibody. So on the blue part, you recognize CD3 on the T cells. So you grab the T cells, and this T cell does not have any lymphoma specific activity, but once it's grabbed by the bispecific antibody, you get taken to the target. So the red one recognizing a target on the cancer cell. So then this bispecific antibody is also called T-cell engagers, able to really redirect the T cells to the target of interest. And then these T cells in close proximity, it forms the synapse and then kill off the cancer cells by puncturing holes on the surface of cancer cells or transmit a negative signal. So once it's done with one cell, then you'll move on to another one. And the advantage of this treatment is it's off the shelf, so it's available immediately. It recruits the endogenous immune cells. Does not involve any chemotherapy or any other assistance. So it's a pure immunotherapy based on just empowering our own immune system. Does not involve any gene modification, and it's given cycles by cycles, so requires multiple rounds of treatment. And mosunetuzumab as the first bispecific antibody was approved for lymphoma, really based on this pivotal trial. So this molecule was in development back in 2015. So it's targets CD20, which is a B cell or B lymphoma cell marker, and CD3, as we know, is a T cell marker. Based on its structure, so we can instead of giving continuous infusion as the first generation, based on the structure, we can give the intermittent dosing, so allows every 3 weeks dosing. And this treatment is given in an outpatient setting. The oldest patient we giving this drug, now is actually 103 patients that actually did quite well. So if you look at this, the plot, this is what we call a waterfall plot. So basically, every single line represents the patient receiving the treatment, and if it's going downward, meaning that there is no total lymphoma reduction. If the line is going up, that means that there is progression of disease. You can see majority of patients actually derive the benefit from this drug treatment with only eight cycle treatment. So it's a fixed duration treatment. Does not require a patient to be on the drug continuously, or some of the treatments until patient have progression. This drug is only given 8 cycles. Could be 17 cycles in special conditions. But 60% of patients had complete remission, 80% of patients had overall response. And this is really in comparison to a historical control. In this setting, only 14% patients would expect to respond to the treatment. So following this, there are many similar bispecific antibodies. This is IgG based, had been approved for various lymphoma, follicular lymphoma, diffuse large B-cell lymphoma, multiple myeloma as well. And we know the first one, the blinatumomab, was approved for patients with acute lymphoblastic leukemia, but it's a third generation. All the subsequent ones are the second generation because we know better how to give the drug and how to design these bispecific antibodies. And there will be more approval in the future. So moving on to the second of this kind of T-cell based immunotherapy is the
CAR T cell therapy or TCR T cell therapy. So basically, this is very different than the one I talked to you about. So this one is what it does is in a patient with the blood cancer, we take the patient's immune cells outside the body because those T cells, either for some reason they are not able to get rid of the patient's blood cancer. But by taking those T cells out and we send them to the laboratory or send them to school, educate them to recognize a specific blood cancer, and then by doing gene modification, and then we expand these cells outside the body ex vivo to millions. So many millions of these cells, they all look the same. They all recognizing the same target. And once this is made, it takes around 2 to 6 weeks for this process to be ready. And once the product is made, patient's ready, these cells will be infused into the patient, and it's only one-time treatment. So that's the biggest advantage of this one-time treatment with many millions of lymphoma or leukemia, myeloma specific T cells. And as early as at day 28, we can see a response. So there are many, this is a very simplified process. There are many variables in this process really determines the efficacy as well as the toxicity of such treatment. But let's look at the first one that's FDA approved back in 2017. And this is for patient with young adult with or pediatric patient less than 26 with acute lymphoblastic leukemia. These patients, they are all relapse refractory to previous chemotherapy-based treatments. So in these studies, 82% of patients received complete remission. So this is the highest response rate we're ever seeing for patients with acute lymphoblastic leukemia in this setting. And in 5 years, 55% of them patients still doing well, still alive. And this is really comparing to a historical control around 10 to 20% of patients. So this availability of this CAR T cell has really revolutionized how we manage patients with leukemia and other blood cancers. And this is the first ever patient who received this CAR T cell treatment. And this is a patient that she was 5 when she was diagnosed, but her leukemia came back in 2011 and relapsed again and again, didn't really respond to any treatment available at the time. So the discussion was really between either she go home, be on hospice, or she participate in a clinical trial, which was a very early stage clinical trial at the time. So she did. She received CAR T cell treatment, the one we just mentioned about, in 2012. And she achieved complete remission a month later after the treatment, has remained in remission ever since. And every year she would take a picture of herself, saying how many years she's cancer-free. And in 2023, she became a college student. She went to the same school that where she received her treatment. So it's quite remarkable. And here's a case of a patient that this was back in 2018, a patient that came to us after so many different lines of treatment, many different types of chemotherapy treatment and radiation treatment, and had blinatumomab, as we said, that's a first generation bispecific, and also had antibody drug conjugate. This is number 9, that's antibody drug conjugate, and more radiation, but the patient continued to have massive masses in the pelvis, in the abdomen, and also very infected ulcerated mass in the left axilla, in the right axilla. And the treatment physician brought the patient to our tumor board for discussion, wanting to get a consensus to recommend comfort care. But CAR T became available, so we are recommending that maybe we should try CAR T. So the patient had CAR T and went into a complete remission a month later. Day 28 scan looks very clean, and 3 months later, the patient went back to work. So some of these patients who has debilitation from is actually from their tumor or cancer. So with treatment, the treatment works. They will improve their quality of life. So to take this CAR T further, so there's actually 2 phase 3 studies really comparing. Can we give this one-time treatment CAR T versus the conventional treatment, chemotherapy, followed by autologous stem cell transplant, which has been the standard care for 20 years. So the outcome is actually the CAR T is the winner. So one-time treatment really outperform chemotherapy plus transplant. So this become now the new standard care for patients in second-line treatment for large B-cell lymphoma. And there are many, CAR T cells now approved, indicated for patients with various blood cancer. And the one with the stars are the clinical trials that City of Hope is part of. And since 2012, we've been doing CAR T cell therapies for patients either on clinical trials or receiving FDA-approved CAR T cell treatment that begins in 2017. So you can see we have treated more than 2,000 patients now, and a third of them actually received CAR T cell treatments on clinical trial. So we have many different types of clinical trials for not just blood cancer, but also solid tumors and also for patients with the infection, including HIV. And a quarter of these clinical trials actually using CAR T cell developed here on campus. Now, this is what we call the IIT. So allowed us to offer these CAR T cells on this campus. So this is I know my time is up, but this is a patient journey, 43-year-old with very refractory acute myeloid leukemia, had a prior transplant from her sister as a donor. We know transplant is another form of immunotherapy. What it does is it completely replace a person's immune system with a donor immune system and hope the new immune system will be able to get rid of the blood cancer, but in this case, it didn't work. But we enrolled the patient on our CD123 CAR T clinical trial, and this CAR was made at City Hall campus here. This is using T cell from her sister who being a donor-derived CD123 CAR T, and the patient was infused with 200 million of these CAR Ts. And day -8, you see those the dark brown colors those are all the leukemia cells in the bone marrow. And day 14, the bone marrow is kind of empty. And day 29, we start to see some regeneration of the blood cells. And day 54, you see many red blood cells and the white blood cells in the bone marrow. So the patient achieved complete remission and went on to a second allogeneic stem cell transplant with her sister as a donor. So what's on the horizon? There are many novel treatments these days that people really looking at newer targets from preclinical discovery to clinical translation. So we call bench to bedside translation. And there are also many novel reagents that we put together, trying out the rational combination of two different immunotherapies or immunotherapy plus small molecules, really trying to hit the blood cancer cell from various angles. The goal is really to have a really high potent treatment with very low toxicity and also being able to preserve or improve patients' quality of life. And this is also being tested in diseases that had never had this chemotherapy before. And we're also moving these CAR T or T cell-based therapies actually to earlier line or first line treatment. And just to echo what previous speaker have been talking about is clinical research is really the best way to gain access to tomorrow's medicine. Some of my patients who get a bispecific treatment back in 2016, the drug was approved in 2022. So the patient had the treatment way earlier than the FDA approval. So just to, it takes a village to do clinical trial to take care of patients. But I think that together with all the efforts, that we should be able to cure more patients with blood cancer. Thank you.
It doesn't matter who wants to enroll, but for a certain type of breast cancer.
Yeah, so we really have not seen a difference in the with these kind of immunotherapies. And again, for the CAR T cell treatment, it's really personalized medicines using your own immune cells. So really, it's hard to compare with others. But I think that if the patient selection is right, the condition is right, you will expect very similar results. In the real world outcome, patients who are not eligible for clinical trials actually continue to derive similar efficacies. Thank you.
Apologizing to the virtual audience that you can't see the slides. We'll have this fixed now.
Turn off the light. Right here, you just click the button.
Thank you, Dr. Buddy, for the presentation on novel cancer treatments, immunotherapy, bispecific engagers, and especially CAR T cells. Let's give our speaker another warm round of applause.
We will now transition to our next speaker.
Hello, everyone. My name is Haley Chung, and I am a 10th grader at Arcadia High School. I am also a part of the high school's junior varsity swim team. And now I would like to introduce everyone to Elaine Sue. Elaine Sue has been a registered dietitian for 17 years and currently serves as a dietitian and supervisor within City of Hope's Clinical Nutrition Department. She is a board-certified specialist in oncology nutrition and a certified nutrition support clinician. She earned her master's degree in nutritional science from the California State University Northridge and completed her internship at LAC-USC Medical Center. Elaine chose to become a dietitian because of her passion for food and a deep curiosity about its impact on human health. Outside of her clinical work, she enjoys visiting restaurants, trying new foods, and exploring diverse cuisines. Her core philosophy is that food should be a source of enjoyment and that balance and moderation remain the essential keys to healthy eating. Her presentation is about food as medicine in Asian communities, culture, family, and metabolic health for cancer and diabetes prevention. Please welcome Elaine Sue.
Hi, everyone. Thank you for the introduction. So today, I want to talk to you about something very important and practical. So I want to talk about food, something we do every day, we eat every day, and this can have a major impact on our health. So why does it matter? Because Asian Americans are the fastest growing group in the United States, and cancer death is the leading cause of death. And also at the same time, diabetes risks are increasing in this community. And what we do every day, how we eat, our lifestyle can make a big impact. And this is something you can do today. So food as medicine. So I want to talk about food, and not just as enjoyable as a social event. Food can affect a lot of pathways. It includes inflammations, hormones like insulin, our gut health like our microbiome, our body weight, and our immune system. These factors are all linked to cancer and diabetes, and this risks develop over time. So small daily changes you can do today and every day can lower those risks. And cancer in Asian American communities, we see more commonly are liver cancer, like we saw with some of the speakers, stomach, colorectal, lung, and thyroid. What we eat and what we do every day can change those risks. Food can make us feel better, have more energy, and also, especially during cancer treatments, it can affect how our patients feel, and especially after recovery. So our goal today is to use the healing powers of our Asian cultural food and incorporate that into our health. Traditionally, our Asian cultural diets are high in vegetables. It's low in animal protein. It's low in animal protein, but high in plant proteins. Traditionally, we don't eat a lot of processed food. We usually do a lot of
family dinners and we cook food at home. And we see Asian Americans having a lower rates of colon, breast, and prostate cancer. And Asian Americans typically have a lower body weight, 2 to 5% lower than the US-born residents. But after coming here for maybe 10, 15 years, after a period of time, our westernized diets tend to be lower in vegetables, high in animal and processed meat, high in sodium, high in super processed foods, and we tend to eat larger portions. This increases our risk for cancer and diabetes. So today, in this Western society, we tend to eat in a fast-paced environment. We do a lot of grab and go, fast food, restaurant foods, even in the supermarket, even if you're getting grocery at a supermarket, we tend to get a lot of pre-packaged, pre-frozen meals. And these meals are usually high in salt and sugar. The solution I'm urging you to do today is to incorporate our Asian cultural food, but we still keep it in a modern society. So why is traditional Asian diet so protective? Usually, Asian culture tends to eat a lot of vegetables, soy foods, tea, fish, seaweed, mushroom, garlic, ginger. This kind of food all lowers our inflammation risk. And over a long period of time, chronic inflammation increases our risk for cancer and diabetes. So I want to talk about vegetables. I can't emphasize how important the vegetables are. Vegetables are very protective. So things like bok choy, napa cabbage, mustard greens, these are cruciferous vegetables, and it protects ourselves from inflammation. Also, vegetables are high in fiber. So when we eat fiber, it slows down our digestion, so we feel fuller for longer, so we don't tend to eat as fast. And also, fiber are also good for our gut. It helps with our gut microbiome. It feeds our gut bacteria. So in long term, it also helps to build our immune system. So our goal is to eat vegetables at every meal. So soy food. So a lot of people are very confused, and people tell me, no, they can't eat soy. It's because it's bad for you. It causes cancer. So I want to tell you it's not true. So soy food are actually, the current research shows that it actually seems to be protective. So why is that? So soy contains things called isoflavin. So I want you to imagine cars on the freeway. So our body produces estrogen, and estrogen kind of acts like fast, speeding cars. So when you have a lot of estrogens, it tends to stimulate cell growth. But instead, if you eat a lot of soy, the isoflavin kind of acts like calm drivers. So it slows down the speed of the freeway and slows down the growth of those cells. So that's why it's important to incorporate more soy. And I want to urge you to make sure that you're eating soy food that are whole soy foods, not processed soy food. So those are where we see the benefits. And tea. So tea are also something we generally tend to drink a lot in the Asian American community. I remember when I was a little kid, when I go to dim sum with my parents, what you drink is tea. You don't get sodas, you don't get juices, you just get tea. You don't have any other choice. So traditionally, we tend to drink a lot of tea. And there's a lot of good compounds in tea that actually acts like protectors around our cells. So when you drink the tea, you have less inflammation. You get the antioxidant benefits from the tea, and it's associated with lower risk of breast and digestive cancers. So I urge you to also swap out your sugary drinks and drink unsweetened tea. It doesn't have to be fancy tea. It could be any tea. It could be green tea, oolong tea, black tea. So just try to drink a little bit more tea. Okay. Next, I want to talk about herbs and spices. And so herb and spices we traditionally use a lot in our cooking.
And so things like ginger, cinnamon, turmeric, garlic, those all have protective properties. So like ginger, it also helps with digestion. It has its antioxidant properties. Turmeric, it also helps with lower inflammation. Cinnamon, we used to use traditionally Chinese food. We kind of use it in like stews, like spices. And cinnamon has been shown to have anti-diabetes properties, help to regulate our blood sugar. Scallions, cilantro, they all have strong antioxidant properties and lower inflammation. So when we use herbs and spices, we can use less salt and sugar. And that's a very easy way to incorporate more antioxidants while lowering the sugar and salt. So we talked about some foods that are beneficial. What about food that we want to limit more? So traditionally, Cantonese salted fish, I don't know if any of you have had that. It's very flavorful. It gives you a punch of flavor. But salted fish is associated with esophageal cancer. Those preserved sausages, instant noodles, those have a ton of salt. It's like could be a whole day's worth of salt. And eating those high salt foods is related to stomach cancer. Alcohol, and some people who can drink a lot, but there's no safe amount of alcohol that you can drink. So alcohol are related to liver cancer, pancreatic cancer, esophageal cancer, many type of disease. So it's really important that we want to limit these. I'm not saying you have to avoid them forever, but you want to try to limit this as much as you can. And healthy weight, very important. When we have a healthy weight, it protects us from cancer and diabetes risk. So when we are overweight, we have excess fat, especially in the abdominal area. If we have excess fat in the belly, it increases our risk for insulin resistance. So it also increases your risk for chronic inflammation. And again, remember when I was saying that chronic inflammation can increase your risk for cancer and diabetes. So we want to lower that. So when you have more central obesity, that increases your risk. So overweight, being obese, is linked to breast cancer risk, colon cancer, liver, and endometrial cancer, to just name a few. So if you have a healthy weight, it supports more insulin sensitivity. So if you continuously have insulin stimulation, it's continuously spike. Your insulin levels keep spiking. It increases your body response to insulin. And in long term, it can increases your risk for diabetes. So therefore, it's really important that you maintain a healthy weight. And you can decide, see if you're at a healthy weight by looking at your BMI, your body mass index. So it's determined by your height and weight. But this is just one indicator. And so it's just looking at your weight and height. And you can see if you're considered overweight or not. But generally, I want to also in this community, Asian American community, you will see higher risk, even though we may not be at an overweight standard for the Western society. So being overweight is BMI over 25 in the Western society. But in Asians, we will see a higher risk, even though your BMI may be 23. Okay, so we have actually a lower threshold for a BMI. So also not just diet, daily activities, just walking helps to improve our insulin sensitivity and our weight. So, and also it doesn't have to be big drastic changes. You don't have to lose 30 pounds next month. You can just lose a few pounds and that will improve your insulin sensitivity, your chronic heart disease, cancer risk. So as I was saying, we want to do small, doable changes and want to give you practical ways to do that. So of course, we love white rice. Asian, we tend to eat that a lot, including me. But white rice is low in fiber. It doesn't make you feel fuller longer. And so just a couple swaps. So if you can increase the portions of high fiber grains. So you can add in purple rice, brown rice, barley, beans, and that will increase your extra fiber intake and antioxidants amount. Next, fatty meat. So, when we go to restaurants, barbecue, like pork bellies, those roasted pigs or sausages, those are very high in fat, especially saturated fat. So if we swapped out just those once in a while and swap that out with fish, tofu, beans, and lean meat like chicken or lean pork, it will reduce our saturated fat intake by a lot. And that can help you with your weight and heart disease risk and insulin sensitivity. Noodle swap. And I know we love instant noodles. Most of us have eaten it before. And even though it is convenient, it is probably not the best thing. It is high in fat, it's high in salt. What you can do to swap it out is you can swap it out with soba, which is higher in fiber. You can also swap it out with vermicelli, which are lower fat. And so that's just some of the noodles that you can swap out. And instead of using the instant noodle packets, you can use broth that will reduce your sodium intake by a lot. And also, we want to increase the intake of the protein. It will help you feel fuller longer. It helps you with your cells to recover. So think about adding like lean chicken, eggs, shrimp to your bowl of noodles, and adding, again, half your bowl with vegetables, mushrooms, it will help you increase your fiber intake a lot. So this bowl will be significantly healthier than a bowl of the instant noodles. And then, we also tend to use a lot of sauces in Asian cooking, soy sauce, teriyaki sauce, oyster sauce. So if you can swap out some of those, I'm not saying you have to eliminate those sauce, but you can use a lot less if you add in more herbs and spices. By adding in the ginger, the garlic, even chili peppers, it will add a lot more flavor and you will have to use less salt and sugar and soy sauce and all that kind of sauces. And also by adding those herbs and spices, it increases the antioxidant properties in that bowl. And then tea, as I was saying, how important tea is in our cultural food. And just swapping out those boba tea, and I'm sorry. So good, but maybe once in the blue moon. So swapping out those boba tea and slushy drinks and juices and soda with unsweetened tea. You can add some flavor in your tea by adding some fresh fruits, maybe a little bit of juice, and you can transition to that change, and it will significantly reduce your amount of sugar intake. Okay? And at the same time, adding antioxidants. So swapping your cooking method is also very important. So when you go to a restaurant, they tend to use a lot of oil or fry foods. And instead of eating that deep fried, those green beans or like those fried chicken, if you swap out the cooking method into steaming, braising, or like flash cooking your vegetables, even a quick stir fry would be much healthier than deep frying foods. So I want you to start with these simple steps today. So fill half of your plate with vegetables or bowl with vegetables. Replace your sugary drinks with tea, unsweetened tea or water, and try to walk at least 20 minutes every day. And what I want you to take away from today's talk is that we want to keep a lot of the healthy properties in our Asian cooking. We want to incorporate that into our daily lives today. And those small little changes, and again, it's small changes every day, it accumulates over time. It's not one special food, it's not one superfood, and it's just little things that you do every day because we eat every day, maybe 3 times a day or even more, right? So those changes, those little changes doesn't need to be perfect. It will make a big impact. And because it's something so we do every day, it is very powerful. Thank you. I think the key is moderation and balance. So people will ask me, like, maybe what's the one superfood you should eat? It really is a variety of foods. So especially like with vegetables, fish, different food give you different properties and different antioxidants. So I like to eat, to answer questions, I think the most common fish that I eat is salmon and cod. It's just because it's easy to buy and it's fatty fish that has omega-3 and it cooks so fast. We have to work, and we need to do something quick and they cook really quick. Same thing with seafood. So I want to try to incorporate seafood regularly. Mm-hmm. Mm-hmm. It's safe. Remember, we're talking about overall eating patterns, right? So if you're replacing salmon, any kind of salmon, and over, a fatty meat, pork belly, it's definitely always better, right? We can, sometimes we worry about toxins, right? Mercuries. So you do want to limit your fish to seafood intake to like maybe 2-3 times a week. But a lot right now, what I'm seeing in the research studies is also that we want to incorporate a more of a plant-forward diet. So a lot of the soy that I was talking about and beans. Thank you. The research does not support that. Our body does its own cleaning. So our liver does a great, excellent job to do that. And there's no research to support that. Thank you.
Thank you so much for the insightful presentation on nutrition. We really learned the important role of culturally meaningful nutrition and healthy lifestyles in disease prevention.
Let's give our speaker another warm round of applause for sharing their expertise, experiences, and dedication. And now we will want to invite the next speaker.
Good afternoon, everyone. Are we ready to meet someone who makes the word busy look completely inadequate? It is an honor to welcome Dr. Timothy Donahue from UCLA Health. Dr. Donahue serves as Chief of Surgical Oncology at UCLA Health, Vice Chair for Surgical Cancer Care, and Surgical Director of the UCLA Aggie Hirschberg Center for Pancreatic Diseases. He is also a professor of surgery and molecular and medical pharmacology at UCLA, where he leads groundbreaking work in pancreatic cancer treatment and research. Now, while most of us are trying to survive the 10 freeway or trying to remember where we parked this morning, Dr. Donahue is performing some of the most complex cancer surgeries in medicine and helping patients fight one of the most toughest cancer that we know. His research focuses on improving treatment and finding ways to detect pancreatic cancer earlier, which has the potential to save countless lives in the future. At the same time, he continues to care directly for patients and families with a level of compassion that colleagues and patients consistently admire. He has also served as president of the Society of University Surgeons and is recognized nationally for mentoring future leaders in medicine and cancer research. What makes Dr. Donahue truly special is that he brings world-class expertise together with genuine human connection. In a field filled with technology, data, and research, he never loses sight of the people behind every diagnosis. Today, we are incredibly fortunate to learn from one of the leading voices in surgical oncology and pancreatic cancer care. Please help me give a big and enthusiastic welcome to Dr. Timothy Donahue.
It's so great to see so many of you. What an incredible community that we've built together. So my ask today is to give the annual update on pancreatic cancer, which I have given for the last few years. But this year I titled it Progress and Hope, because I think that there's been so much great progress that's happened over the last year or so that I'd like to share with all of you. Just a few disclosures. What we're going to cover today is how pancreatic cancer is changing, how we diagnose and personalize treatment, the current treatment options, new and emerging therapies, and where I think the field is going. So what's new this year? Well, between last year and this year, when I gave you the update last year, there's been development of more treatment options than ever before. Genetic and tumor testing now guides care for all patients. And we recommend that genetic and tumor testing be done on everyone because it can affect treatment. There's hot new drugs that are targeting KRAS that are showing early success. There's cancer vaccines that are in development, personalized, and they're moving forward in advanced phase trials. And immunotherapy is starting to show promising combinations. The vaccines are a type of immunotherapy, but these are all treatments that we didn't even talk about 10 or 15 years ago at all. So as I said, genetic testing it's standard of care. It's recommended for all patients with pancreatic cancer. There's two types of genetic testing that you can have. One is what's called germline testing, and the other is somatic or tumor testing, and we'll review both of those. But it's really important that you get it done because it helps guide treatment decisions. It helps guide clinical trial options. It helps determine family members' risks of developing pancreatic cancer. So this is all a key part of personalized care. So here's a genetic landscape of pancreatic cancer. On the right there, the columns are patients. The rows are different mutations that happen in those patients' tumors. And they develop progressively as the tumor starts to develop. The precursor lesion to the cancer is called a PANN, or pancreatic intraepithelial neoplasia. These are akin to like colon polyps or polyps in the colon. Unfortunately, they're not detectable. Can't see them on CT, MRI, endoscopic ultrasound. They can only be seen microscopically, which is what's handcuffed us a lot in diagnosing pancreatic cancer at an earlier stage, is we can't really detect or see the precursor lesions. But we do know from analysis of them and ones that have been removed surgically, the mutations that are present in them, and the mutations are progressive mutations that happen that go from a precursor lesion to a cancer. And that KRAS mutation is one that happens early. It's called a founder mutation. It's present in those precursor lesions, and then as the lesion progresses, you get progressive mutation like the P53 and other genes that can happen. But that KRAS is present in 95+% of pancreatic cancers. So as I said, it's important to get tumor testing. It's important to get germline testing, because this slide summarizes how we kind of think about things now. On the left there is, standard chemotherapy, which we'll review. But then we ask ourselves, is KRAS mutated? And what specific mutations are present in KRAS? Because now there are drugs that target specific mutations in KRAS. And so we want to know what the profile of your tumor is in order to match you up with a specific drug that targets that mutation. Very few patients have KRAS wild-type tumors, which you can see there, 4 to 8%, but we're interested in other mutations that might be present in these tumors that have different therapies that can target those mutations. And then on the right there, as I said, this is the germline testing where you can see BRCA1 or 2, and we know specific chemotherapies and we know specific targeted therapies that are more effective in patients that have these germline BRCA mutations. So this is kind of how we think about things. And at the outset, the first question is what does the germline profile look like, and what does the somatic or the tumor testing profile look like? So again, why it matters, and I keep emphasizing it because it's so important, and we can help you here get your germline tested. We can help you here get your tumor tested. We do this routinely on all of our patients now. But identifies patients who may benefit from those targeted therapies, helps match patients to clinical trials, provides information for family members, and increasingly influences treatment decisions. So how do we monitor the cancer over time? How do we monitor how you're responding to the treatments that you're getting? There's the circulating tumor DNA that we talked about that detects tumor DNA. It can provide direct information. And then there's the good old standards like CA19-9 and CEA that are commonly used. They're helpful. They're not perfect, but we now have this circulating tumor DNA to help us to monitor your response to treatment in your cancer much more accurately than we were able to do before. So these tools are complementary, but yet another thing in our armamentarium to help treat you and monitor how you're responding to treatment. So how do we treat pancreatic cancer today? The treatment depends on the stage of your tumor, your health, your overall performance status or your health, and the biology of your tumor, how aggressive it looks like the tumor is or not aggressive. We take that into consideration too, and personalizing your treatment and determining what treatments are best for you. And our main approaches are surgery, chemotherapy, targeted therapies, immunotherapy, and then there's radiation therapy. So chemotherapy still remains the backbone of treatment of pancreatic cancer. The most common regimens that are used are, I'm sure most people in this room know that, FOLFIRINOX, which is what we call a 5-fluorouracil based regimen, 5-fluorouracil or FU, and it's called FU for a reason. There's gemcitabine and nab-paclitaxel or Abraxane is another commonly used regimen, one that has really been established largely due to the work by Dr. Tempero, who's here and will speak after me. There's Nalirothox, which is a variation of FOLFIRINOX that was a positive phase 3 trial that was led by Dr. Zev Weinberg, who's in our group here. But those are the most common regimens of chemo. There's many, many more, but these are the most common ones that we use as the main backbone. There's some emerging regimens. There was a combination therapy called PAX-G, which is cisplatin, Abraxane, and gemcitabine that was tested in a small study in Europe that showed a signal. And so there's going to have to be a larger trial with that. But that's one area of excitement over the last year where I think that the combination chemotherapies, the options have expanded. So the goals of the treatment or the chemo are to shrink the tumors, control the disease, and improve survival. Treatment's becoming personalized, right? Not one size fits all. And as I said, our treatment is increasingly guided by genetics, by patient goals, by tumor behavior, and we take that all into consideration. Fortunately, here at UCLA with the Hirschberg Center, we have an integrated practice unit where there are not only all the medical professionals there from surgery, medical oncology, radiation oncology, but we also have professionals, experts from supportive services like nutrition, like psychosocial services, like genetic counseling, and others who can help with your treatment. Because the treatments have become more effective, because people are living longer, we're talking about things like maintenance therapy now. And so those are the treatments that we have to transition into to maintain the treatment of your tumor and keep it repressed. And also talk about treatment sequencing more than we did before. So KRAS 2026. Critical regulator of pancreatic cancer. There's now targeted therapies. There's pan-RAS therapies. So many drugs emerging to target KRAS. And these, as I said, I think will be part of a backbone of therapy for pancreatic cancer moving forward. Okay, what about immunotherapy? This is another hot area of focus now. Immunotherapy works well in some cancers, melanoma, renal cell cancer, kidney cancer, not as well in pancreatic cancer. And that's because the tumor is really good at blocking the immune system. But we're trying to bypass that and circumvent it and get around it with new strategies that are emerging. These are combination therapies with immunotherapies. We're very excited here at UCLA about targeting adenosine. We have a clinical trial where patients are treated before surgery with an adenosine inhibitor, which is a type of immunotherapy. The anti-tumor vaccines, which we'll spend a couple minutes talking about, and also cellular therapies you've heard of, like CAR T cells, which are very early on. So tumor vaccines. So you think about vaccines for infectious diseases like COVID or other viruses or other bacteria. This is a very active area of research and trials for cancer and pancreatic cancer. There's different vaccine classes, so it can either be a protein, it can be a viral vector, it can be mRNA. mRNA is the class that was used for the COVID vaccines. We learned a lot from COVID about how the immune system responds to mRNA vaccines. And there are some in development now for pancreatic cancer. So these personalized cancer vaccines, the personalized ones are made from a patient's tumor. And they train the immune system to recognize the cancer, like they train the immune system to recognize an infectious disease. And some early results from one trial, which I'll highlight, is they generate a strong immune response, delay in recurrence, and there's larger phase 3. So that's the last step before something becomes approved. Clinical trials ongoing. This the main vaccine work, or the first place to really start doing this for pancreatic cancer was at Memorial Sloan Kettering. And this was based on some science that a surgeon there did, who found that patients who survived a long time, when he looked at their blood, 7 years out. So 7 years out from having surgery for pancreatic cancer, and those long-term survivors, when he looked in their blood, he found T cells that matched T cells or immune cells that they found in the surgical resection tumors. So those patients, the presumption here is the patients who responded longer generated a really good immune response and a long-term durable immune response. So moved into thinking, how can we try and generate this with a vaccine? And this is that personalized vaccine. This is the phase 1 study. It's now in a phase 2/3 study, which we have open here at UCLA. But so these are patients who underwent surgery, so their tumors were removed. They were sent over to Germany to BioNTech, which developed one of the COVID vaccines, and they were analyzed to find the specific mutations present in the tumor, and then they generated a vaccine to target those specific mutations. And as I said, about 50% of the patients responded or generated an immune response to that mRNA vaccine. And the recurrence-free survival in those patients who generated the 50% that generated that immune response has not been reached compared to the patients who did not generate an effective immune response, who their recurrence-free survival was much, much shorter. A lot of promise, and as I said, now this has moved into a phase 2 study for patients after surgery. And this is something that we have ongoing here at UCLA. So clinical trials are absolutely critical. They provide access to new therapies. They help advance the field. And there's been a ton of advancements in the last year. Many of our current treatments come from trials. And so I encourage you to ask about clinical trials early. But the gatekeeper for all of this now is that germline and somatic tumor testing to see which ones you'd be eligible for. So standard therapy 2026. Chemotherapy, I talked about the regimens, FOLFIRINOX, gemcitabine, Abraxane, NALIRIFOX, this new PAX-G regimen. So I said, we're thinking about maintenance therapy now because people are responding so well. And it's a lot to ask someone to undergo multi-agent chemotherapy for a long time. And you don't need me to tell you that one. And building on the standard, right? So targeted therapies, immunotherapies, actually thinking about local treatment of metastatic disease or tumor that's spread to the liver or other areas. So key takeaways and why we're optimistic. Treatment is improving. Genetic and tumor testing are now routinely done and they're essential. New therapies are emerging, those KRAS targeted treatments, immunotherapy combinations, vaccines like we talked about. Clinical trials are expanding options for patients. There's so many more now than there were even a few years ago. And so there's more progress and hope than ever before. So that's why I titled the talk today, Progress and Hope 2026. So thanks again for your attention. And
Thank you, Dr. Donahue, for sharing this informative pre-recorded presentation and important updates on pancreatic cancer research and care. Although Dr. Donahue is unable to join us live today, we will be collecting audience questions and comments and will help connect them with Dr. Donahue after the symposium. Let's give Dr. Donahue a warm round of applause for his continued dedication to improving pancreatic cancer care and outcomes.
There's a small program change on the program. Dr. Yang Hee-woo won't be here today due to a family emergency, but in the future symposium, they'll be attending. Now we're transitioning to our next speaker.
Good afternoon, everyone. My name is Mark Shin, and I'll be introducing Safa Mohammed. Safa Mohammed is a project coordinator at the City of Hope's Tobacco Cessation Program. She earned her bachelor's degree in biopsychology from the University of California, Santa Barbara. While interning and working with the County of Santa Barbara Health Department's Tobacco Prevention and Cannabis Education Program. At City of Hope, she continues to encourage diverse community members' involvement in tobacco-related health education and cessation activities in hopes of fostering a healthy, well-informed environment. Next, I'll be introducing Safi Shri. She's the program coordinator at Asian Pacific Partners for Empowerment, Advocacy, and Leadership, where she supports national efforts to advance tobacco prevention and cancer control in Asian American, Native Hawaiian, and Pacific Islander communities. As a native Mandarin speaker with roots in cross-cultural communication, Safi brings a deeply community-centered approach to her public health work. Safi holds a Master of Public Health and Global Epidemiology from Emory University Rollins School of Public Health, and a Bachelor of Science in Cognitive and Behavioral Neuroscience from UC San Diego. Her experience spans research, community program development, and data-driven health communication across nonprofit and international settings. Driven by commitment to community health, Safi is passionate about empowering diverse communities with the knowledge and tools to lead healthier, tobacco-free lives. Next is Joseph Hayden. Joseph Hayden, he's a senior IT program manager in the Enterprise Technology Group at City of Hope. Joseph has extensive experience working at United Healthcare, John Moore Health, and Stanford School of Medicine. He also taught at New York University and Touro College. He holds a law degree from Brooklyn Law School, as well as a bachelor's degree in political science from City University of New York. Joseph is passionate about combating the normalization of commercial tobacco use within groups like LGBTQ minus tobacco in the San Francisco Bay Area. For many years, Joseph has worked pro bono, traveling nationally and continuing to do advocacy about the global devastation brought on by the tobacco industry, particularly regarding the effect on the LGBTQ+ and other targeted populations. Please welcome Joseph Hayden.
Joseph will be joining us virtually from the Bay Area in California. I will commence with his presentation. Joseph, are you able to see the screen and unmute yourself?
Yes, thank you, everyone. Good afternoon. I am Joseph Hayden. I'm honored to be invited here by my amazing coworker, Sophia Young. I've been attending her meetings for years now at work. And I learned very early on that marginalized communities were of little value to big tobacco. In the early 1990s, when I was still a law student, I started writing articles in the law school newsletter or newspaper about the insidious industry and was told, you can't fight a tidal wave. Well, I wasn't alone, and that often meant, and that doesn't mean that we should remain silent. Health equity has been a very important element of my activism. I got this diagram here from the Truth Initiative, which is a great source. Anytime I observe demographic health inequity, my conclusion is that it's due to tobacco industry targeting tactics. I've always thought globally about this issue whenever advocates would make some inroads into tobacco control here in the United States, the industry would just move on to its next target. This was exemplified one time, which I distinctly remember shortly after the United States banned big tobacco from sponsoring events like the Virginia Slims tennis tournament, which I protested at. The industry just picked up where it left off by sponsoring music events throughout Asia to addict new populations and acquire fresh victims, I mean customers. Okay, thank you for moving to the next slide. This is some about, oh no, go ahead, if you can go back, please. These are some of my speaking engagements on tobacco. I like to say that my biggest credential is being a loudmouth about this subject. I was on a panel at the second annual Endgame Summit last summer in Chicago that was hosted by Action on Smoking and Health. I gave a continuing education presentation at City of Hope on campus for the Pride Health Symposium a year ago. Last week at the Board of Supervisors in San Francisco, I advocated for smoke-free bar patios, which has been in the news a lot here. I also regularly speak at City Council and environment justice forums about tobacco retail licenses and smoke-free multi-unit housing, especially here in the Bay Area. Okay, please go to the next slide. Lest anyone think that I have something against people who smoke, the whole reason I got into this was because I lost close loved ones much too soon to their tobacco addiction. These are all my family members who died very young. In particular, I want to point out my cousin who died at age 35 from osteosarcoma, which he developed in his pelvis. He traveled much of the last 6 years of his life. He was diagnosed at 29 and tried a lot of experimental treatments in various countries to no avail, unfortunately. And of course, there's me with my father, who died at 50 from his years of suffering from his tobacco addiction. And unfortunately, his own mother died at the same age at 50. So that's a family tradition I definitely don't want to continue. Next slide, please. Every tobacco activist, I find, has a curmudgeon who approaches us with an anecdote like, but my grandmother smoked every day until she was in her 90s. So this is my response to that. You can also survive by putting on a blindfold and running across the freeway, but why would one? All right, next slide, please. So I coined the phrase peddlers pushing poison because I really think it's important to call tobacco, commercial tobacco, what it is. I like the alliteration, but the statistics here are what really drive me crazy and keep me up at night. So we're in California, where 40,000 of our fellow Californians die of tobacco-related illness every single year, 480,000 Americans, and 8 million people globally, because 20% of the world is addicted to tobacco, unfortunately. Next slide, please. So the racist quotes on this slide are almost too difficult for me to read out loud. If you can't read the text there, it says, Big Tobacco decided Asian Americans were a profitable target due to their, quote, genetic predisposition to smoking. I don't even know what the hell that means. And the other graphic here is an important quote that was part of an expose many years ago from a model who was in these ads, quoting an RJR executive who said, we don't smoke that shit, we just sell it. We reserve the right to smoke for the young, the poor, the black, and the stupid. Next slide, please. So cigarette filters are they're made of non-biodegradable plastic, and they are the most littered item on Earth. I asked many of the youth who may not have experience with tobacco-related illness in their families to get engaged for the environmental reasons also. So despite a little progress that we have made, we still have a very long way to go. Next slide, please. I like to point out also the true costs of smoking. Tobacco industry was up in arms when prices, minimum price per pack was set, but a $10 price pack is nothing compared to what it really costs our society, which is much closer to $40 a pack. And every Californian, regardless of whether they smoke or not, pays $487 a year for the cost it is to our society. And tobacco industry does spend a lot of money, $500 million a year, excuse me, just in California, where smoking has actually gone down tremendously to try to get their deadly products sold. Next slide, please. Another thing that keeps me up at night is that many of us have retirement plans and investments in what are called diversified funds. But what I try to point out is that diversified funds very often include tobacco stock. So since we come to work every day fighting tobacco and diabetes, I think it's important that we make sure that our retirement funds aren't putting 1 cent into these industries. So it's not always easy to do, and not everyone has financial literacy to do it. But I think that our retirement plans in particular, should be based on sustainable funds, and that we should have the option to do that very easily. So I encourage everyone to think about that, because as you can see here, the American Medical Association, American Lung Association, and other companies that fight cancer all the time had to do a about face and make sure that their own retirement plans weren't inadvertently investing in this industry. Next slide, please. So I'm glad I'm not the first person to talk about RFK Jr. today, but these are difficult times. The White House Chief of Staff is actually a current tobacco industry lobbyist. Reynolds just made a huge contribution to Ballroom this past week, and they got an invitation to Mar-a-Lago, and they're actively trying to influence the administration to ease up on flavored vapes, which end up unfortunately being very attractive to the youth. And the youth is a demographic that tobacco industry is looking to addict. I don't know if you're able, Safa, to play the video there, but this is a video of RFK Jr. During a congressional hearing. He's actually popping a nicotine pouch into his mouth on live TV, trying to be discreet. And he puts it in his cheek. And there's plenty of evidence that he is buying them, because he's been photographed outside of stores carrying the Zyn packages, and he has actually recently started endorsing nicotine pouches. Next slide, please. So I am constantly upset at the product placement of these combustible cigarettes, and in particular, the one on the right bothers me. The original avatar had Sigourney Weaver playing a medical doctor in the exam room, by the way, on a spaceship hundreds of years in the future, smoking a cigarette. What could possibly go wrong? And even more recently, this Netflix series called Three Body Problem had all these PhD students in London. This is a modern era. It did take place in the 1940s, but you'll notice that the protagonists are all smoking. They linger on the protagonists' beautiful faces. None of them ever cough. And when the director of this series was asked why he had all of the smoking going on the screen, he said he couldn't figure out what the actors would do with their hands. To which I respond, maybe he needs to go back to directing school. And the same thing goes for James Cameron and his Avatar. Next slide, please. So, as Sophia and I have discussed numerous times, vaping devices are not a smoking cessation device. Despite what the current administration might want to push, the FDA has never approved an e-cigarette. And the problem with these devices are that they may have started off with lower amounts of nicotine, but now, of course, they can. The customers were demanding, more, and unfortunately, the industry was willing to provide. So, one vape device can have the equivalent of 400 cigarettes. All right, next slide, please.
Wow, thank you so
much. Oh, that
much.
is it. Yeah, thank you for letting me fire hose you with all this information. Thank you.
Thank you again, Joseph. That was such a wonderful. That was a wonderfully passionate presentation, and we look forward to hearing more about your experience shortly during our panel. I will move on to Safi. She is joining us from Atlanta, Georgia, virtually. And if you'd like to continue or commence your presentation, that would be wonderful.
Good afternoon, everyone. I'm Safi. I'm the CAPE Program Coordinator at Appeal, the Asian Pacific Partners for Empowerment, Advocacy, and Leadership. I'm joining you virtually from Atlanta, Georgia. I think it's truly an honor to be here with you today. Next slide, please. APPEAL is a national organization advancing health for Asian American, Native Hawaiian, and Pacific Islander communities. I coordinate CAPE program, one of 9 CDC-funded national networks supported by the CDC Division of Cancer Prevention and Control, which is focused on commercial tobacco prevention and cancer control across all 50 states and 6 U.S. associated Pacific Island territories. Everything we do is community-rooted, and that community lens is exactly what I want to bring our topic today. Next slide, please. Thank you. When people hear tobacco and Asian Americans, they often assume the risk is low, but the hidden impact tells a very different story. Tobacco is a known driver of cancer, lung cancer, throat cancer, and more. But what is less known is its connection to diabetes. Smoking worsens insulin resistance, damages blood vessels, and makes diabetes harder to control and treat. For our communities where both cancer and diabetes rates are rising, tobacco is quietly making both conditions worse. And the danger does not stop with the person who smokes. Asian American teens are 15% less likely to discuss tobacco with a healthcare professional, meaning that secondhand exposure within families and homes goes underaddressed, silently affecting children, elders, and everyone in between. Next slide, please. This hidden impact is not happening by chance. The tobacco industry has deliberately targeted Asian American communities, sponsoring cultural festivals, advertising in Asian languages, placing more tobacco ads, and fewer health warnings in our neighborhoods. Today, that same predatory playbook is being used for vaping, with flavored products and social media campaigns aimed directly at our youth. The environment our community lives in, the billboards, the stores, the digital spaces, is saturated with tobacco messaging. That is an environmental impact too, and we cannot just ignore it. Next slide, please. Vaping is the newest and perhaps the most, the previous one. Thank you. Vaping is the newest and perhaps most hidden face of this crisis. It is sleek, flavored, falsely perceived as safe. We got all of the flavors out there. We got mango, blueberry, and menthol. And just this month, I believe that the FDA approved new flavored vaping products, making them more accessible than ever. I think the science is clear because vaping causes nicotine addiction, high blood pressure, asthma, lung, and heart disease, all of which compound existing cancer and diabetes risks. And with today's financial pressures, housing instability, and academic stress, our youth are turning to nicotine as a coping mechanism before they even understand the consequences. Next slide, please. I wanted to share something personal because community always starts with lived experience. My uncle, who grew up in China, has smoked for most of his life. And like so many in our communities, nobody around him ever questioned it. Tobacco was simply part of the daily life, a gesture of socializing, of hospitality, of being an adult man in Chinese culture. Years later, he developed lung disease. And even then, the conversation in our family was not easy to have. We did not want to cause shame. We did not want to point fingers. That is what saving face looks like in practice, and that silence has a real cost. Research confirms that what my family lived. Studies show that in many Asian communities, tobacco use is deeply normalized through cultural tradition, gender expectations, and social bonding, making it far harder to recognize as a health risk until the damage is already done. And when the person affected is someone you love, you understand why community-based conversations, not just clinical warnings, are the only thing that can truly change their behavior. This is not a failure of our communities. It is a call for our communities to lead the change. Next slide, please. And that is precisely what community-based work is for. At APPEAL, we believe the most powerful intervention against tobacco's hidden impact is not a clinical program alone. It is a trusted community member who likes you, speaks your language, and understands the cultural silences that allow tobacco to hide. We train community health workers and trusted messengers to bring this conversation into cultural gatherings, faith communities, and family spaces, because that is where hearts and minds actually change. When communities are informed, connected, and supported, they become the most powerful force to prevention. Next slide, please. So what exactly do we do together? We name the hidden impact on cancer, on diabetes, on our environment, on our families. We create safe spaces for community to talk openly about tobacco without the shame. We train trusted messengers from within our own communities. We engage youth to gently reach their parents and grandparents, maybe in culturally respectable ways. And we demand accountability. Big Tobacco earns $500 billion a year. Those tax dollars must come back to our communities, funding multilingual succession programs and lung cancer screening accessible to all. Because tobacco impact is hidden, but our community power is not. Thank you.
Thank you so much, Safi. You put that so wonderfully, and thank you so much for sharing your expertise. We will now transition towards the panel discussion. I first want to open up questions to the audience. Do you guys have any questions for either Joseph or Safi about tobacco cessation, lung cancer screening, tobacco prevention? Yeah. Your question or your don't smoke? Yes, 100%. Don't consume tobacco products in general. Alrighty, but no worries. I have some questions to ask our panelists. And so first I'll start with Big Tobacco makes $500 billion in revenue every single year. And oftentimes they employ pretty predatory tactics, especially with the marginalized and vulnerable communities. And that keeps people hooked on their products. When people are ready to quit, they're met with many challenges. How do you think we should hold the tobacco industry responsible for education, community outreach, cessation, and lung cancer screenings and treatment caused by tobacco usage?
Well, unfortunately, some of the tactics they've used have been to develop so-called safer products like vapes, and so I don't know if we can ever trust them to manage it themselves. I think the programs that have worked best are the ones that take the settlement funds and have it directed by the states. Unfortunately, right now, with the Office of Smoking and Health being completely wiped out by the current administration, a lot of states that don't have the smoking cessation resources within their own governmental, within their state governments, basically have no cessation funds right now. California, of course, has been a leader. I tell people in California, you're already paying for smoking cessation. If you go to the California Kick It site, you can get texts and you can get support on the phone. You can get emails. Any way that you want the support to quit, it's already being paid for by California taxpayers. So fortunately, we do have that here.
Yes, that is perfect. Thank you so much for that response. And I'm sure it resonated with a lot of our audience members and maybe their feelings. Safi, do you have anything to add?
Yes, I would like to touch a little bit from our side as appeal. I think the question you ask is really good because I think that statistic alone says everything. $500 billion in revenue built significantly on addiction, and the communities in this room and the families we serve are part of that equation. They are the ones who got cooked, who got sick, and who are now navigating lung cancer screening, cessation programs, and treatment, often without enough support. So how do we kind of hold them accountable? I think first, through policy, we need legislation that requires tobacco and vaping companies to contribute directly to public health funds, specifically designated for prevention, education, and community outreach and cessation programs. I think tobacco settlement funds has existed since 1990s, but the question is whether these dollars were actually reaching the communities that needs them most, including Asian American, Native Hawaiian, and Pacific Islander communities were too often left out of the mainstream funding streams, right? Secondly, I think through transparency, these companies must publicly disclose how they're marketing their products, who they are actually targeting, and which communities are being most exposed. Because for right now, much of that marketing is happening quietly, I would say, on social media through influencers in language other than English, reaching our communities without accountability. Third, I think through community power. When communities are educated, well-organized, and vocal, they become the most powerful force for accountability. And very informed, connected community is one of the industry cannot just ignore. And that is where organizations like Appeal come in. We kind of help communities understand their rights, their risks, and their voice. I believe lung cancer screening and cessation support must be fully funded and made accessible to everyone, regardless of language, insurance, and immigration status. If the industry's products cause the harm, the industry must help fund the healing.
Thank you so much. That was a wonderful response. And I believe with both what Joseph and Safi said is how important policy is. Remember to vote. Remember to really dive into what local policies affect you guys, as well as statewide and even federally and nationally. Education is everything, and there's a lot of information out there. So we encourage you to understand what can affect you through policy and vote in your health and your community's health best interest. And I will ask one final question. In many Asian cultures, topics like cancer and smoking can be sensitive. What cultural factors like stigma or saving face most affect decisions about quitting or addressing tobacco exposure?
I don't mind just saying one quick thing that I've learned over the years is that perhaps one of the most respectful ways of addressing it is letting people who smoke know that it is others around them that they are harming. Because sometimes if you just say, you should quit for your own health so that you can live a long life is not enough. It's when their loved ones are affected. I know I grew up in a household where I got constant ear infections, and voila, it's because my father was a chimney and we didn't have the wherewithal to speak to him about it. And after many years of smoking in our faces, he realized that it was harming us. And I think is much more effective than just haranguing him the way I did and begging him to quit for his own health.
Yeah, absolutely. It has a very personal impact for a lot of people, not only in this room, I'm sure, but also in our communities. And Safi, did you want to mention anything else?
Yeah, I want to thank you first for this question because it's so close to my heart. I believe that in many Asian American communities, tobacco use has been normalized for generations. It is social, it is polite, it is what the men in the family do after dinner. And because of that deep normalization, bringing it up feels like an accusation, like to the person itself. Nobody wants to kind of shame a family member, right? Nobody wants to disrupt the harmony of the household. That is kind of saving face in practice. And what happens as a result? People often stay silent. It might be a grandmother, breathes in secondhand smoke every evening and says, oh, it's nothing. Or it might be a teenager watches their father smoke and thinks this must be acceptable. I think that is why the silence become inherited. So what we need to do is gently reframe the conversation. Instead of just pointing fingers, we invite families to protect each other. Instead of calling tobacco a personal failure, we call it a community health issue that deserves a community response. I think when trusted messengers from within our own communities, people who understand these cultural dynamics from the inside are the ones who can open these doors in ways that clinical programs simply just cannot.
Awesome. Thank you so much. And I feel like the moral of this tobacco panel is to meet smoking and vaping, as well as other tobacco consumption, with compassion and understanding. Empathy goes a long way, but also understanding that there are evidence-based solutions out there. There are effective ways to quit tobacco products. So there is hope in stopping. Thank you so much to our panelists, Joseph Hayden and Safi Zhu.
Thank you for having us.
Thank you.
Thank you so much for leading the panel.
Let's give our panel another warm round of applause for sharing their expertise, experiences, and dedication to improving community health.
As we conclude today's symposium, we want to sincerely thank all of our speakers, community organizations, volunteers, sponsors, healthcare professionals, youth ambassadors, patients, survivors, caregivers, and attendees for joining us.
Please remember to complete your post-event survey and submit your passport for the raffle drawing.
Together through education, partnership, culture, innovation, and community engagement, we can continue building healthier futures beyond cancer, diabetes, and tobacco.
Thank you everyone for being a part of today's symposium. Safe travels, and we hope to see you again next year.
Have the raffle and the raffle. Invite you to complete the survey. Complete this one. If you have a phone, please help complete the survey for this symposium, and we have the raffle drawing right now. Sorry about taking for so long. We have so much wonderful speaker and valuable information only once a year, and then share it with the audience. Thank you so much for staying with us. And then please help us to complete this survey, and then we will have the raffle right now. Say the number.
923455.
923460. 923452.